Good morning, and I would like to welcome everybody who is present in the chamber and all those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would like in particular to welcome Councillor Suzanne Welbury for her first meeting of the committee, and I would like to add, for those of us that are in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also like to request all members to place their phones on silent and to try and ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item, and to keep those succinct and concise. However, I will close down the debate to ensure we keep to time if needed, and would ask you indicate early to guarantee your question. As the meeting is being streamed in the usual way, I would like to remind you that your comments will remain accessible online as the meeting recording remains on the Council's website. I'd now like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies for absence from Councillor Diane Rogers. We've also had an apology from Councillor Sue Woolley, Executive Council for Community Engagement, Integrated Care and Registration and Coroners. We've also been advised that Councillor Morgan and Liz Bull will be slightly late. Thank you, Chairman.
Thank you. In which case, I'd like to move on to agenda item 2, the declaration of members' interests. This is an opportunity for members of the committee to declare any pecuniary or other interests. Do members have any interest to declare? Councillor Kendrick, please.
Thank you, Chairman. Just mention I'm a stakeholder governor of LPFT.
Okay, thank you. In which case, I'll now move on to agenda item 3, the minutes from the 14th of June. These minutes can be found on pages 5 to 14 of the agenda pack, and as I will take it on block that they've been read by also, do I have a proposer for those, please? Councillor Ray Wotton, seconded Councillor Morgan. All those in favour, please show. Thank you. Abstentions? And those against? Thank you, they're carried. I'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda, and supplementary announcements were circulated on the 18th of July. I refer to section 2 of the supplementary announcements and my proposal to change the date of the meeting in October from the 11th to the 4th of October as well. I hope I'd have the support for that. Councillor Ray Wotton, please.
Yes, thank you very much indeed, Mr. Chairman. On Appendix A, on your Chairman's announcements, I welcome the House of Commons report into NHS dentistry. I know we've got it on the agenda later on, but it's really good to see that it's a topic that's been raised, because all too often across Lincolnshire, many people are having to pay for dentists, and I think that's wrong. So hopefully we're going to have a good debate later on and look forward to conclusion. Thank you.
Thank you, Councillor Wotton. Councillor Smith.
Thank you, Chairman. With regards to the joint Humber and Lincolnshire Health Overview and Scrutiny Committee, from the perspective of many of my residents, the news within your supplementary announcements about the preferred option being in Grimsby is a welcome one, as I know a sizable number of my constituents and those in Market Rasenwald use those services. I appreciate that obviously is not the case for all members present and their residents, so I look forward to this coming to us in September so we can have a proper airing and discussion on this. My second point, Chairman, if you'll permit me, is with respect to Appendix B and the penultimate bullet point on page 30 of your announcements. Whilst at present the details are not yet known, the principle of reducing the time taken to train a doctor and getting degrees, this is slightly, to my mind, disturbing, as they've tried similar experiences before with varying degrees of success, and sometimes you do occasionally get some horror stories. So I think it would be helpful if we could get some more information on what that actually entails so that we can properly scrutinise that, Chairman.
Yeah, thank you, Councillor Smith. We will, of course, keep a close watching eye on that. We are hopeful that in September we'll have the Humber Acute Services Review come through. At the moment in time, they are saying that we have a committee that deals with it and that they don't feel that they need to be coming to speak to us directly. We've pushed back quite heavily on that. I totally disagree, and we will continue to push that they come to this committee. Do I have any Councillor Mackinson-Saunders?
Well, given that most people from the area that I represent go up to Grimsby, I think that your recommendation is completely correct. I'd like to second it if you're proposing that. They certainly should come.
Yeah, thank you. I mean, to be fair, we've pushed back and we've had some conversations, and we will make sure that, most certainly, that we do everything we can to ensure they come. Any other comments on my announcements? No, in which case I'm going to propose that the meeting of the Health Scrutiny Committee scheduled for the 11th of October be rescheduled to Wednesday the 4th of October at 10 a.m. and my announcements are noted. Do I have a seconder for that proposal? Councillor Hayes. Thank you. All those in favour, please show. Thank you. That's supported unanimously. Thank you. We'll now move on to agenda item 5, NHS Dental Service Update. This item was circulated as part of the agenda pack on pages 31 to 50 and is an update since the committee last considered this topic in January. I'd like to welcome in person our presenters, Sandra Williamson, Director of Health Inequalities and Regional Collaboration for NHS Lincolnshire's Integrated Care Board, Carol Pitcher, Senior Commissioning Manager for the 5 Integrated Care Boards in the East Midlands, and Kenny Hume, Chair of the Lincolnshire Local Dental Committee. Could I ask you to present the report in about 5 to 10 minutes and take questions at the end, please? Thank you.
Thank you. Thank you for inviting myself, Sandra and Kenny today to present this dental update to the committee members. I'll just go through some of the salient points from the report. So obviously this is the first update since myself and Sandra presented papers in January 23 on the Lincolnshire Dental Strategy and the collaborative commissioning that was taking place. Obviously since then, from the 1st of April, the commissioning of all NHS dental services has now been fully delegated to the Lincolnshire Integrated Care Board. In terms of that and the contracted services and the commissioning, this includes all dental services. So it is the high street dentistry, community dental, specialist services and the hospital services. So it is the full range of NHS dental services. But to note, private dental services obviously are not within the scope of the Lincolnshire ICB. The current contract was introduced back in 2006 and that is still the contract that a lot of the commission services are based on today. And during that time, obviously, there's been quite a few changes in terms of commissioning primary care trusts and then NHS England and now with the ICB. Obviously, over those years as well, there will have been changes in population. We obviously commission a contracted level of activity, and through those years we do try to adjust that need in terms of what's commissioned by looking at like an oral health needs assessment. We did that back in 2015-16. That was a full refresh, and at that time it did identify some additional services to be commissioned, which they were procured and in place by 2020, and then we are now undertaking another refresh of that to see again where if there are any gaps analysis and what procurement we need to undertake in the coming months. I suppose one of the main things that usually does come up is that unlike general medical practice, with dental practices there is no patient registration system. So a patient is free to choose to attend any dental practice regardless of where they live. That the dental practice itself then is responsible for those patients whilst they're undergoing a course of treatment. And there is then some guarantee periods for that treatment. But usually once that treatment is finished, there is nothing contractually that then says that they have an ongoing commitment to a patient. However, most practices we know do see patients as regular patients of their practice, and on the basis of that they do then invite them back to do those recalls to assess their oral health. In terms of the dental services we have across Lincolnshire, we have included some maps that show where currently across the county the practices are based, and of those which also provide orthodontic services. I I'd also like to point out that we do have within Lincolnshire 3 contracts that actually provide services from 8 a.m. to 8 p.m. 365 days of the year, and that is to provide both routine and urgent dental care. And then in addition to that, we have tried to commission other practices to provide extended hours that go into the evenings, weekends and bank holidays as well. So we have that out of hours cover for urgent care as well. I think within the paper there is information on the categories for what constitutes urgent dental care, so that's within the paper. And then there's some signposting information as well to say if there is an urgent dental care need, the route that either a patient of a practice would follow, and also a route for a patient that doesn't have a regular dental practice. There is some details in there within the paper around some of the specialist services that's commissioned as well. So we do have the Lincolnshire Community Dental Services who provide treatment to those with more complex physical or behavioural needs that can't be seen in a primary care setting. And we have 7 clinics across Lincolnshire to support that service, as well as with the children's extraction service being supported by the United Lincolnshire Hospitals Trust. And the provider that we have for the community dental clinics as well does undertake some dental care for us for those who then are unable to attend a clinic and need to be seen in their home or a care home. But that could also lead to them then needing further treatment in a clinic setting. We also have the intermediate minor oral service, which is a specialist intermediate service. And again, that's provided across 4 locations in the county. And that service is, I think, in terms of primary care, a real asset, and does as well support the secondary care dental services significantly in terms of managing referrals in a primary care setting. And then we do have the services that we commission with United Lincolnshire Hospitals Trust as well. I've included the latest dental charges information in the paper, and also some information for how patients can access like exemption certificates, or if they're on a NHS low income scheme. If I move on to the section 5, the dental access. So obviously following the restoration and recovery of services from the COVID-19 pandemic, in terms of primary care dental services, I think it is still acknowledged there is still a backlog of NHS dental care which accumulated over the period that either practices were closed or were restoring to full capacity, and that has been recognised nationally. With even recent national guidance that was released in June this year, that in terms of those restrictions and the impact, they've adjusted the contractual thresholds for our dental contractors and their performance this year. There is some graphs included in section 5 that show the dental activity for Lincolnshire and how that compares to the Midlands average. So for Lincolnshire, that at May 23 was at 65%, whereas the Midlands average was 78% and national was 76%. So obviously the trend for Lincolnshire is lower than our colleagues in the Midlands or national. I think in terms of the level of retained patients being seen over the last 12 months, that is gradually restoring to pre-pandemic levels. And for Lincolnshire, that's now at 84%. And then I've included figure 3, which shows the overall access rates for Lincolnshire ICB and how that compares to the national position. So overall, the population accessing NHS dental services, the rate for Lincolnshire is slightly higher than the national average, and the same for adults. but unfortunately for children, it is showing that we are under the national average. That is one of the, when we've looked at this data and the work that we're now doing on the dental strategy and the access theme, that we're going to focus on to see how we can look at improving that access for children to dentistry, and also looking at is there other initiatives in terms of that may help from a prevention for children's dentistry, like fluoride varnish application schemes. There is then the visual graph that shows the level of dental access across Lincolnshire Integrated Care Board, and you will see that the darker areas are where it's the lower access. So that there are obviously within that map of Lincolnshire, certainly across to the east of the county, is where that darker and the lower access rates can be seen. The following figures just give a bit further breakdown in terms of showing around age groups and where we sit with adults and children in terms of access compared to England access rates. So again, it does show more with the children that we are further away from the averages there. In terms of new patients seen, there is at figure 7 that just have a graph that shows, as well as retaining the current patients that were being seen by dental practices, there have been a number of new patients being seen by dental practices in Lincolnshire, and over the last year or so that has gradually increased, which I think is a good sign that some new patients are able to gain access. I think just pointing out in terms of 5.9 and the recall interval, I think historically there has always been this perception that everybody needs to go to the dentist every 6 months, but obviously part of the contract reform that came out last year is to really look at those recall intervals, and that they're based on patients' all health status and age, etc. So it could range anywhere between 3 and 24 months going forwards, and obviously, you know, dental practices should be explaining that to patients when they attend as well. We included a section on private dentistry, but obviously in terms of providing any information on this, we don't have that as an ICB. And also just to note that dental practices are independent contractors, and they will always have a mix of NHS and private dental patients, and also they can provide a course of treatment that is a mix of NHS and private. In terms of section 7, this was just to provide an update since April 22 of where we are with the dental contract handback position. So we have had 4 contract terminations since April 22, and that includes the most recent one, which was the Bupa practice at Skegness. The main challenge that has been cited in the reason for these terminations has been around the difficulties that they face with recruitment of dentists to be able to deliver that contracted activity. And although we've tried to work with them, and the incentives that we've got available in terms of golden allows and attracting workforce, some of the providers decided that they felt that still wasn't going to be able to necessarily address the workforce situation. So they had made that decision to terminate the contracts. And obviously the workforce, including recruitment and retention, is one of the 4 themes that we've got in the Lincolnshire Dental Strategy. When we get a termination, we do try to go back and work with the contractor and have a conversation to see what support, what other offers we can put forward to try and work with them to not lead to the termination. But unfortunately, they can still then submit that written contract notice, which is a 3-month period then in terms of close down of the practice. We always work with them, and asked them to work with us on a communication letter to patients, so that we can give those messages about how patients in the interim post-closure can access dental services or urgent dental care. We would like to obviously as well ensure that all of that activity that we do receive back from a terminated contract is not lost, and that is then held in terms of then looking at what we reinvest that as either an interim solution whilst we await procurement, so we can use that to support additional services, or whether we're in a position to do what we term as a dispersal, which is actually allocating that activity out to other dental practices in an area if we've got sufficient dental practices to undertake that activity. In terms of just covering the closure at Skegness, we have secured a number of interim urgent dental care sessions across the East Lindsey area. Some of this is within Skegness, but then some is within Louth and Woodall Spa. And those sessions, although we've referred to them as urgent dental care, this is sort of a slightly local flexible scheme that we've developed to enable urgent dental care, but also if there is need for a course of treatment that prevents the deterioration of oral health further, or needs to be within this interim 24-month period, needs to be undertaken, those sessions can also carry out that treatment as well, which is a new urgent dental care session approach that we haven't commissioned in the past. So those sessions started on the 1st of July, so they're ongoing, but we're also continuing to try and explore and gain additional access within Skegness itself, because we appreciate the transport arrangements and distance to travel is not ideal for certain members of the public within Skegness. I won't go into too much detail around the Section 8, which is the recovery initiatives that we had in place last year. There was quite a number across the Midlands, and obviously within Lincolnshire a number of those were undertaken by providers or accepted in our specialist services. And at the moment we're currently looking at the investment schemes for this year, working with all the 5 ICBs. In terms of then...
Are you okay just to wrap it up? I'm just
sorry,
conscious we're sort of 15 minutes in
yeah,
now. Thank you.
I mean, I'll leave, in terms of commissioning and procurement plans, obviously we can answer questions on the dental strategy because we brought that paper previously. Obviously I've detailed what's happened with national contract reform to date, but work is still ongoing with dental contract reform. We are carrying out that review of dental access, and that will link into the investment for this year and also future procurement plans. We are at the final stages of the procurement process for Mablethorpe, so hoping to get that outcome. So that's been something that I know we've brought to previous updates in terms of Mablethorpe, and around the flexible commissioning. I've probably covered that in terms of some of the schemes that we're going to look at, or we've looked at for the urgent dental care sessions. Yeah, and collaborative working. Obviously, we work with the local authority, the public health team, with our dental professionals, and also we do engage with Health Watch. So I think in terms of communications, I just put some examples in the paper. And I think we'd just like to finish by saying we do acknowledge the challenges that we have in Lincolnshire around access to services. And we are aware from Health Watch about patients reporting that they do find that dentists are not taking on new patients. I think the contract is part of sort of some of the issues moving forward, and we know that is on the programme for national, and I think it will be we will need to consider how from a local area now, and the ICB can influence those conversations and look to how we best meet the needs of the population. And I'm aware that the committee members have obviously been cited the House of Commons Select Committee report from last week, and I think a lot of the conclusions and recommendations in there are possibly some of the things I think we've already identified in the work that we're doing and with the Lincolnshire Dental Strategy. So just like to assure the committee that there are elements in that report, and it does suggest ICBs and how they could be doing more. But I think, you know, I'll let Sandra and Kenny come in on that, the work that's happening with the dental strategy and the details in there. Thank you.
Okay, thank you. I'm going to move straight into questions. So I think a lot of that will be covered as we go along. So I've got Councillor Allen first, please.
Thank you, Chairman. Thank you for the presentation. Very similar to the one 6 months ago to a certain extent. You said 2 questions, Chairman. Well, the 2 questions I'd like to ask, but I'm not really expecting any answers, so I'll make some statements as after I raise the questions. I'm not really asking for answers to the questions. So the question would be, you know, when are we going to be able to provide NHS dentistry to the 75% of the people in Lincolnshire who can't gain access to it? And when are we going to move away from a dentistry model that is targeted, like much of the NHS system, at cure, and cure in dentistry is taking teeth out, as opposed to prevention, which seems to be really what dentistry ought to be about. It's preventing people having to have teeth taken out. I left I didn't leave NHS dentistry. I was thrown out of the practice in 2006 when a new contract came in, and my dentist refused to operate under it. So I've been private ever since. I did attempt to get back into the NHS system in about 2010 when Bupa opened a NHS surgery in Sleaford. But when I went for the checkup, which was free, I was told, why have I come? Because I don't need any teeth out. So I said to the dentist, well, I don't go to dentists to have my teeth taken out. I go to dentists to have a descale and polish because that prevents my teeth falling out. And to which they told me, well, that's not on the NHS, you'll have to pay for that. So I decided I may as well go private. If that's what NHS dentistry is providing. It's not preventing, it's simply wanting to take teeth out. So there isn't really an answer to that, because the answer, because the issues there are all fundamental to the problems that you've just been talking about. It's a contract that doesn't work. It's having dentists that don't want to work in the NHS system, predominantly because it doesn't allow them to do the sort of things that they feel they ought to be doing. And indeed, people may not like it, but will pay privately to have their teeth looked after properly. As you pointed out right at the end of your presentation, it is a very difficult and if in reality a desperate situation, I think, that dentistry finds itself in across the nation and particularly in Lincolnshire. And I don't honestly know what it is that's going to happen that will change that matter. And we end up with an unfortunate situation where some people will continue to try and work within the NHS system. And I must admit, at the end of your presentation 6 months ago, I did go onto the website to find out where I could get an NHS appointment, and it was Mansfield. That was the nearest place that had a vacancy, which just illustrates the issue to a great extent. So you have 25% that will try and work within the system properly because they've got no alternative. We got 75% that don't. Some of those will not be having any dentistry treatment whatsoever, and a majority, perhaps of the 75%, are working within the private sector because at least it's worthwhile paying the money to make sure that you don't have to have your teeth taken out. What is difficult, though, is that rather than trying to resolve the issues that are fundamentally causing these sorts of difficulties, all that seems to happen, and this is not recent, it's not within your watch, it's been happening for 20 years, if not longer. We know what the problems is, we know what might take place to resolve it, but all we do is pass responsibility from one organisation to another organisation. And the latest one that's been passed the parcel is the ICB, and the ICB has now got a 3-year strategy to try and work out what the solution to the problem is. And in 5 years' time, we'll find, or 5 years after the 3 years, we'll find that whatever it is that's come forward has not been delivered, and we'll be having the same conversation again, and somebody else will be passed the parcel to do it. That's all that seems to happen, I'm afraid. And it's not a, I'm not criticising the people that are working in it in terms of being responsible for it, but it does seem as though across the piece, from central government downwards, nobody's prepared to get to grips with this issue and actually bring a solution to it, mainly because it's probably going to cost a lot of money. So that's my comment.
Before I get a response, Councillor Allen, I'm going to try and wrap it up a little bit myself, because I had a similar actual question that I'd like to ask, and that is, in paragraph 5.8 of the report, it lists those areas with the most issues with access to care. So what is being done differently and innovatively to improve this across the East Coast, South Holland, North Kesteven and Boston? And similarly, like Councillor Allen, I visited the .gov website yesterday, and I noted that no dentists within 40 miles are taking on any new patients whatsoever. Also, can you update us on where we are with Bupa, stating they are considering closing both Boston and Sleaford's clinics as well, which of course is only going to create further access?
Thank you, Councillor. Thank you as well. I think I'm coming from a clinical perspective here. I chair the local dental committee, but I also chair the local dental network. So that's an NHS organisation, and I'm responsible for strategy, really, clinical strategy. I think the report from the Health and Select Committee has come out at a very appropriate time. You will have read it. You will see the problems that we face. The problems that we face are not local specific to Lincolnshire. The problems we face are national, really. So in a similar chamber somewhere else in the country, they will be saying exactly the same things here. I think you also need to know that NHS dentistry has only ever been commissioned for 50% of the population. So it's never been 100%, never ever. We're not talking 1947 now, with respect. Access is most challenging in the most deprived areas. Dental practices don't want to, historically didn't set up there. They went away from there for reasons that you can perhaps understand. And the lack of workforce underpins everything, really. If you can't have a workforce, you can't provide services, really. Now, I'm a lot more positive about what's going on in Lincolnshire for many reasons, really. We are the only area in the Midlands to have adopted a dental strategy, a workforce strategy, and a lot of work has gone into that. We have a plan. I personally went to Kerala in India in beginning of May to look at overseas recruitment. You will probably have seen in the workforce plan for the NHS, they're talking about increasing the number of dentists, increasing the number of therapists, increasing the number of hygienists. That's fine, but it will take 7, 8, 9 years before that comes through. So what do we do in the meantime, really? And we are not producing enough dentists in UK. I've heard it said that we are producing enough dentists, but they're all working in the private sector, or they're going down the private sector. We have shortages in the private sector in Lincolnshire as well, so it's not specific to the NHS, really. It's throughout. So we need an interim, we need something, otherwise services will continue to falter, really. So I've been out there looking at that, and you probably saw in the Health and Select Committee the barriers to overseas recruitment. And again, that's something that we are aware of, whether it's coincidence or not. But when before we went to Kerala, There's two exams: overseas registration 1, overseas registration 2. When you pass both exams, then you can be accepted onto the performers list to be a dentist, to work in the NHS. Before we went, there was 2 sittings, 200 candidates each per sitting, so 400 in a year. There's 1,700 waiting on the list. That's the GDC's, General Dental Council's, own figures. So as you can imagine, if you're only sitting 400 at a time a year and there's 1,700 in the waiting list, this is just for the first part, I may add, not the second part. You can see the bottleneck. You know, but now they've changed it, and we've now got 600 per sitting. So we've gone from 400 to 1,200. So big change, really, big change.
Thank you. I'll allow you to come back, hopefully with a short question, please, Councillor Rowland.
A very quick one. The problems that we're experiencing are not new ones. These have been going on for years and years and years and years, decades, 2 decades probably. Whilst any solution, I suppose, to actually resolve the issue, be it workforce ones or dealing with the private public sector sort of issues, is very, very, very welcome. I do have reservations about going going internationally into countries where they are training people to provide healthcare provision. And it's not just dentistry, this one, it's across the NHS piece. And effectively recruiting them to solve our problems. I don't see that as a very moralistic solution to the issue, to be honest. Unless you're going to tell me, frequently comes out, that India trains an awful lot more dentists than they need, because they know that the NHS is always in India trying to recruit them to solve the problems that we've got in the workforce here. So, and I don't believe that either. I'm quite sure that there's healthcare provision in these countries which is suffering as a consequence of our recruitment policy. Even you admitting this is a short-term solution to the problem, whilst we resolve it in other ways. And I say, after 20 years, if that's the way that we're going about things, I think it's quite poor.
Thank you, Councillor. I feel that we do need to train more of our own. We do need to encourage more of our own to want to stay in the health service. I think that's important. And the contract that we currently work under started in 2006, and by 2008 the Commons Health Select Committee then said that the contract was not fit for purpose. We're now how many years down the line. Now, I had never been to India before I went, so equally I went slightly sceptical. I can assure you that the area we went to Kerala in the south of India. One of their issues there is they produce too many dentists, and there's dental unemployment there. Now, I didn't say it was a short-term fix. I said it was interim, really. And I think it's to provide a service. It's going to be the overseas recruitment has always been in the health service, and I think that the combination of overseas recruitment plus more of our own trained graduates is the way to go. But I just would highlight that there is definitely an urbanisation in dentistry, that dental graduates want to stay around their own universities, big cities where the universities are. There's always been that urbanisation, and we have to be innovative, and we have to try and find ways that's going to encourage graduates to come to Lincolnshire, really, which we are trying our best to do.
Okay, thank you. And just could you touch on what's happening with Bupa in Boston and Sleaford as an update, please? Thanks, Carol.
I just want to go in very briefly in that. Before I let Carol answer here, if an organisation like Bupa can't make it work with all the millions of pounds behind them, I think that says quite a lot, really.
Hi, yeah, just in terms of an update of the Boston and Sleaford Bupa practices. Obviously, you know, Bupa did make the announcement in terms of closures and looking at sale of certain practices. At the moment, they have identified potential new owners of both of those practices, which is good news. And we're currently working through, because we have to do our own due diligence checks and assurance to be, you know, in terms of that contract and it moving in terms of the ownership to those new providers. So that's ongoing at the moment, but everything seems to be moving in the right direction with those two, that we're not anticipating that they will come forward as terminations at this stage.
Thank you. That is actually a bit of good news, so thank you. Councillor Ray Wotton.
Thank you very much, Mr Chairman. I'm a great fan of the NHS, always have been all through my life. I'm looking at the charges here on page 38, even £25 for a basic check. To some people in my area who can't afford dentistry, how are you encouraging those dentists who are thinking about leaving the service to go in private? How you encourage them to stay on the NHS? Thank you, Chairman.
It's been highlighted that dentists are dental practices are small businesses, and what we have in effect is a combination of NHS and private, and I think it's fair to say that the private side of a practice subsidises the NHS side. That's how it works.
So, Chairman, it's all about money then? Thank you.
It's not about money, it's about care as well, but a business, if a business can't pay its bills, a business doesn't operate, and therefore more people, whether it be NHS or private, suffer as a result. It's fundamentally a business, it's got to stay in business.
If I go back, I mean, I'm 71 now. I go out through my years of my life, and I've been to the dentist regularly. And as each year goes by, you get less treatment, less checkups, don't scale your teeth, don't clean your teeth for the same money, and charges are going up and up. I don't think that's right. Thank you, Chairman.
I just want to point out that we don't set the charges. The charges are set by the Treasury, really.
I think the reality is, you know, it's not often I defend dentistry, but if you look at the lower level, you know, you could end up with a filling on that, and, you know, someone else might walk in there and just need antibiotics, and it's that balance of, I can see the inequality, most certainly. So I've got Councillor Parkin next.
Thanks, Chairman. In some ways, a lot of the answers to the questions have already covered, because I was particularly interested in Lincolnshire, because recruitment for Lincolnshire, because I know it's such a problem throughout all areas of the public service. So that was where I was looking. But just, I used to be one angle you didn't cover in the international recruitment, and I do to an extent share those same concerns as well that we've heard, is, are you looking at our refugee community in terms of recruitment who are in the UK? I used to be a trustee of the Lincolnshire Refugee Doctor Project, and I'm just interested if there are those projects in a similar vein for dentistry where we are looking at recruiting people, overseas medics, but who are already in the UK.
So the situation is yes. But we're stymied by the restrictions imposed by the General Dental Council just now. That's the issue, because they have to sit what's called overseas registration exams, part 1 and part 2. You have to have a contract, beg pardon, you have to have registration to sit, to be a dentist, and these are the issues that we're facing just now. And these are issues with the General Dental Council. But, as I said, I'm encouraged because they're aware of the situation as well.
That was going to be my follow-on. Is there a recognition nationally in government that is a plausible solution to the problem that we're facing?
I think the answer is yes. There's a lot of ministerial pressure going on just now to try and overcome that problem, but it's one of, we want it to happen, but we are stuck because of the regulations and the restrictions imposed by the General Dental Council just now.
Thank you. Councillor Morgan.
Thank you. Well, first of all, I would echo a number of the comments that have already been made and concerns. Personally, I also found that I could not get an NHS dentist in Grantham. And I managed to sign my daughter up as a child. I now realise I was quite lucky from the sounds of it to have been able to do that. But the dentist would only take her on as an NHS patient if I went private. And that's what I've had to do. And just to give you a feel for what that now means, I am facing £6,000 worth of dental treatment as I'm now hitting a point where all my old fillings and everything else need replacing. £6,000, I can't afford it. So I'm just hanging on and hoping that those teeth don't continue to play up. I've even had people come up to me recently who can't afford the NHS fees. And this is hugely, hugely worrying. So we've got this underlying problem in across our community. We've picked up the fact that we've got a 75% shortfall in service, the delivery versus demand. I think we do need to be having something far more innovative coming out from the government, more funding from the government. One of the thoughts I've got, it takes 5 to 7 years to train a dentist. You have to have 3 A levels at A grade in sciences to even consider going into start training at our universities. And the interesting thing there is we seem to be actually offering top world-class quality training when they get that far, but you wonder how many people fall even at the hurdle to get to that stage. So I think we can't underestimate the skill set that these dentists do have. To me, perhaps we maybe need to be starting to think outside the box. We're juggling, our strategy is all about juggling limited resources. How do we squeeze even more and more out of what we've already got, and what we've already got isn't enough to meet demand? So why don't we, for example, take on schemes that they might in the army, where we say to a youngster, okay, we'll pay for your training. Join the NHS, work for the NHS for 5 years or however long, and we will cover that cost, because it's worth it to us for what they could deliver in the community, and obviously they gain experience, and we'd hope maybe then give them a handshake to stay on and become more experienced. I think there is a solution. I just think there isn't, in truth, the political will behind it, because whilst MPs are earning 70,000+ a year, dare I say, they actually aren't going to the dentist and thinking, I can't afford to come here. Maybe we need a few MPs who actually can't afford dentistry care, and I'm pretty certain that quite quickly they'd start coming up with a solution. And I do actually feel sorry for all those who've got the task of trying to fill these gaps. I really do, because it is completely unenviable, and working really in an intolerable situation, doing the absolute best that they can. I think the extending the hours is really encouraging. It's a really good idea, because that's the other area of concern I've got. It's acute care. It's a 24/7 access to care. The only other thought I've got is that in some regards it's also, but clearly from what we've seen, a postcode lottery. Where you live makes all the difference. Maybe we need to start prioritising, saying rather than having those lucky patients who do get the NHS dental treatment, that's more around, less around emergency care and more around just going for their checkups. Should we perhaps be thinking like you would perhaps in a hospital and saying, or for other issues, medical issues, these people are a priority because of the level of need that they have. So we instead spread our resource to match the need, rather than it's you happen to live here, you've been signed up to that dentist for 30 years, therefore you're okay. Do you see what I mean? Maybe we need to start thinking more more like that. But I'd rather we weren't in that position. I'd far rather that you know, the idea. I'd be really interested to hear the thoughts around the idea of paying people to train and supporting youngsters, promoting dentistry within schools. How many of us actually ever thought about becoming a dentist at school? I really would be interested in that. Thanks.
Thank you. Before I get a response, I will ask that members try and come up with 2 questions. I know it's useful to have the background, but I'm just conscious of time and trying to make sure that everyone gets the opportunity, and also for our presenters to be able to try and come up with a rounded answer.
I think there's about 6 different questions there, actually. So first of all, we're very active in the schools with the Talent Academy. Very active. Because obviously we want people who are. We don't need to sell Lincolnshire to them; they're already here, and you know we're seeing the first shoots of people who've gone through the Talent Academy process or go to local schools, going away to come back again, and this is of course what we want. It has been muted about a sort of like a tie-in, if you like. That's certainly been muted in the last one of the last reports. You talked about postcode lottery. Some of you may have picked up the bit today about children's teeth and admission for general anaesthetics. That's been in the media this morning. Having to wait 18 months for a general anaesthetic, this sort of thing. Just like to say that in Lincolnshire we are on top of it, and we have a facility both in Lincoln and Boston, and the general anaesthetic waiting list in Lincoln, thankfully, is very, very low. But it does go on to the business about prevention. And dental decay is a totally preventable disease. And we are seeing children being admitted. It's the most common admission for general anaesthetics in children is to take teeth out. And so as part of prevention, Lucy's team in the Oral Health Advisory Group are doing a great job in education and prevention, really.
Yes, Councillor Morgan.
Thank you. Yeah, just coming back, you didn't answer the point about whether we could actually pay for training to encourage people to work within the NHS and to then retain them working within the NHS.
When you say we, sorry.
So as in our body, do we have the ability to do that? If not, could we lobby the government so we do? And on the teeth removal, my daughter's about to face that actually, but it might be misleading. She has 0 fillings, but she's got to have tooth removed because of an issue with the way they're growing, and that might muddy the waters on the removal of the children's teeth. Just making that point, really.
Thank you. I mean, obviously that is a point. If you get an impacted tooth or something like that, but the vast majority of children who have a general anaesthetic, it's for dental decay, I'm afraid.
Okay, thank you. I've got Councillor Smith next, please.
Thank you, Chairman. As has sort of partially been touched on, but I think it's important to say is let's be frank. And I can remember before 2006, getting an NHS dentist then wasn't perfect, but it was nowhere near as hard as it is now. The reason NHS dentistry fell off a cliff is because the 2006 contract said, oh no, we're not going to pay you to take 2 fillings out, we're going to pay you under the UDAs. And the dentist looked at that and went, well, I'm not being paid for my time and my skill, I'll go elsewhere. And quite frankly, who can blame somebody in that situation? As has already been said, Chairman, 4 out of our 6 districts are what I would call grossly underprovided for with dentistry. And the impacts of that are fairly obvious. Until there is what I would call substantial contractual reform, tinkering around the edges, I'm sorry, it's not going to do anything. You're going to be trying to put a band-aid on a gaping hole when you need a tourniquet. And it's the same for international recruitment. You can try and do that till the cows come home, but eventually, like with nursing, you will hit a saturation point, and word will get back, oh, I had a bad experience, or actually it's not what I thought it was, and actually their own country's going to go, actually, we kind of want you here, or we want you to go elsewhere because we can get more money for you and you can earn more money over there. Like in Australia, they're paying GPs 300,000 plus with houses to come over. We can't compete with that. So it's all well and good saying we use international recruitment, Chairman, but this sounds very much like deja vu with GPs, and we both know how well that's going, to be frank. It goes back further, Chairman, because much like GPs, they are a business. So there is a question, actually, is the construct of them right in the current climate? Much like general practice, they are their own independent businesses who then go into the NHS. Does that need to be looked at by the government? I'm aware there'll be a significant cost to that, but the current system, Chairman, simply isn't fit for purpose. And our residents are particularly acutely affected here in Lincolnshire, and for far too long. And for the fact that the contracts never had the intention of even a 50% number of patients being treated by the NHS is absolutely crazy, Chairman. I appreciate that's not everybody's fault here, but it needs to be said. And one final point on the fees, Chairman. I pay into a plan, so I go every 3 months to see the hygienist. That is not cheap, and that's NHS fee. So God knows what that would cost me privately. I certainly couldn't afford that, but I can remember a time when it was the NHS actually stopped prevention totally for about 5 or 6 years when I was in education. It was, oh no, if your teeth aren't falling out, we're not going to scale your teeth, we're not going to polish your teeth. And that's the result we're now in, Chairman, is those 5 and 6 years have done a huge amount of damage, and we're now the bomb's now gone off, and we've now gone, oh dear. But who's given that instruction? Because the public certainly, that's not what they believe their NHS dentistry was for. It wasn't pulling teeth out, it was to prevent, Chairman.
I feel I'm being grilled here. I think I just go back to the report from the select committee. It sums it up in total, what you've said. Just to make you aware of when the contract came in 2006, it wasn't tested, it wasn't piloted, it just appeared, and it certainly is not what we expected as clinicians. I have the advantage of working both in practice and at the hospital, so I see both sides. I've worked in Lincoln for an awfully long time. I won't tell you how long, but it's a long time, and I'm still active in practice, really. So I see things firsthand. I'm actually reporting from the front lines, so to speak. I've owned my own practice as well, so I know the issues we have in trying to maintain a business, really. But the reason why the contract changed was that prior to 2006, you could set up a practice, you could just put your nameplate up in the door, and you could set up a practice. If 1 year you worked really hard, 5.5 days a week or whatever, there was no control in the budget. There was no control in the budget. So what happened was NHS England decided to cap the budget, and that's where the UDA system came in and all that went with that, because then they can control the budget. So one of the telltale things this year is I think we've got something like a 400 million underspend in NHS dentistry. So that's 400 million pounds not being spent on NHS care because the workforce isn't there to provide it. And that's a real damning statistic, isn't it?
Thank you. You may very briefly, because I'm just conscious we're running out of time.
Thank you, Chair. I accept that point entirely, that it wasn't tested, it just appeared. I remember it appearing very well. But the fact there's a £400 million underspend demonstrates that contract, as you rightly said, and it's not your fault at all, but as you rightly said in 2008, that should have been gone within 2 years, not now, and it's still here. So it begs the question, Chairman, you can have select committee reports till the cows come home. The need to, and not for us to do, obviously, but government need to do something about it because it's our residents that are suffering.
And the point you make about our residents suffering, absolutely. It's professionally you don't take any sort of, you see what's going on, people can't get a dentist. It's professionally, it's awful, really. And I'm not happy with that in the slightest. Just one thing that I would say is that, just to use the analogy of a plane, crash. Planes don't fall out of the sky by and large. It's a series of events, and we're right down at the bottom of that event. We haven't quite crashed completely yet, but we're only a few feet from the ground. And this is something that, as I said, I know I'm going back again, but the report from the Health and Select Committee, which was an all-party report, I think has pulled no punches and is very, very accurate and up to date.
Thank you, and I think it's good timing now for Liz to come in, to be fair. I know that Health Watch has done a heck of a lot of work.
Yeah, thank you for your presentation, Carol. And as you know, Health Watch have been working very closely in raising the patients' views of Lincolnshire. And you'll know our Chief Executive actually went to the Select Committee, particularly to represent those seldom heard patients. So we're very versed of the issues. I think a lot of points have been already made, and I liked your analogy. Well, I don't think I liked it, but it kind of resonated, the plane crash. But you did in some of the questions you're answering, Kenny, gave some hope. So what hope have we got for the residents of Lincolnshire when we will see improvements based on the strategy and recruitment? And just a one question around the recruitment. So obviously the numbers of doctors that are going through the overseas doctors, have we got any held in that chain? And if we have, when will we see them come into fruition? Thank you.
So in terms of hope, we have we did talk about the dental strategy that is currently being implemented. The one item I didn't talk about was the Centre of Dental Development, which was highlighted in the report, the long-term health service report, you know, the plan. So you probably have, you know, in various conversations heard about, you know, possibly a dental school for Lincolnshire and all the rest, really. But we want to try and set up, and it was mentioned as a priority, a centre for dental development. Now, we're working very hard with the University and Health Education England, all sorts of partners, really, the ICB in particular, really. And it's the ICB who have really driven this. And the one thing I really, when you talk about positivity, the connections that we have with the ICB, with the medical director, with the chief executive, in Lincolnshire, we've got that connection that other areas just don't have. I was lucky enough to be on the CC primary care group of the CCG from a long time, and we've developed real close connections with the ICB. And that is a real positive compared to other areas. I can assure you of that. So our plan, I mean, the Centre for Dental Development is embryonic. I think that's fair to say. And what we see this is in partnership with the university is a centre, if you like, a sort of a very mini dental hospital, which is responsible for education, it's responsible for training, and it's responsible for getting graduates into the NHS, really. It is an NHS-styled initiative here. And we're working very hard on that, really. We don't have a premises yet. There is a template in Suffolk just now, and we're working very closely with those to see what's going on. There is a dental plan coming out, I may add, in the next, it was hoped before Parliament recess, but I don't think it's going to make that, which drills down into this far more, really. So, as I said, we're working with Suffolk. We're working on our own, but we're liaising with Suffolk and what they are doing, really. But the aim is to, as I said, provide a centre for training, education, pastoral support, professional support as well, so that we can have people, and the plan is that eventually they will move into the NHS. And just to pick up, Councillor, your point about tying in, we hope that by providing professional support at the start of the journey, that the aim is that these people will stay in Lincolnshire, put down roots, and hopefully increase the workforce. but that is a real sort of positive, and other areas are not doing that. There are one or two areas doing that, but as far as we're aware, we're the only area in the Midlands where that is being pardon? Yeah, we're working on it right now. No.
Councillor Allen, please, if you can come through the chairman. If you wouldn't mind responding, please, because I'm sure that's a question we would all like to know.
Yeah, I mean, in terms of an actual date, we don't have a date. We can't have that, but we're working on this as a project that's giving our immediate attention, really. Let's put it this way, Suffolk have got a premises, we don't yet, but we are hoping that this is something that could happen in the next year or two. I mean, we're working very hard to do this, actually. No. Why?
Okay, thank you, Councillor Allen. Thank you, that's really useful. I think it'll be fair to say, and I'm sure we'll say at the end, that we'd be incredibly supportive of anything that's moving in that direction. I know a number of MPs have already supported the idea of this from Lincolnshire as well, so absolutely. I think there was an article on Calendar last night, and it's much more positive here in Lincolnshire than what it certainly sounded in Yorkshire. I've got Councillor Cleaver next, please.
Thank you, Mr. Chairman. On section 2.5 of the report, you mentioned that there is still some misconception amongst the public. And so my first question is, do you think you're doing enough to correct those misconceptions? Those of us who are elected representatives never like the public having misconceptions. It doesn't help us in what we do. It doesn't help us to represent them. I'd be very pleased to know, because I find myself on social media correcting these misconceptions all the time. So if you can do anything in your comms from the ICB, I know you have a very good comms team, very sophisticated comms team at the ICB. If they could do a little bit more about this, I think it might be helpful. Then on a point of slightly more detail, in section 3, about the geographical spread in our county, you mention, which is pleasing to see, that in South Kesteven, where I come from, there are 12 practices, and that 7 of them offer orthodontic services, which again is very good, looking at the spread across the other districts. However, it is rather disappointing to note that of the 12 practices in South Kesteven, not one of them offers extended hours or any urgent out of hours care. And so my question is, do you think that's satisfactory? And if not, are you able to do anything about it, please? And Chairman, I think given the tone of this debate, I think it would be helpful if we could put out a resolution at the end of the debate that is fairly strong in terms of calling for our politicians in Westminster to take more account of what we've heard today. Thank you.
Thank you. Yes, in terms of the communications part of your question, we do, I try to include some examples in the paper, but we do work with comms teams now, and we are now linking in with the ICB comms teams. So we were just talking earlier, weren't we, about that we need to regularly get these messages out there. So we do explain to patients how they access service, if it's urgent care, what those routes are. And we do try and engage with Health Watch and PALS and other colleagues as well around the signposting messages. So, you know, we do take that on board, and we will be looking at that again from an ICB point of view. In terms of the extended or out of hours arrangements, the South Kesteven issue, I think what we've tried to do each time we've then had to commission new services, where we've had those gaps and recommissioned, we've tried to do that as an extended access practice or an 8 to 8 practice, because within South Kesteven we haven't had the same gap isn't there or need to recommission. We have to work with the existing practices there, because we do have quite good levels of access, well, the commissioned access within South Kesteven. So what we tried to do before, because obviously accepting that they may still need to access out of hours arrangements and things, that was one of the reasons why we looked at Sleaford as one of the more recent 8 to 8 practices that we did. So at least in distance-wise for South Kesteven, it wasn't as great a distance to travel as perhaps they might have had to travel before to Lincoln, say. But that will, every time we look at that commissioning gap and the model for commissioning, we will be building in those out of hours arrangements.
Thank you. I'm glad that you're aware of it. Thank you.
Thank you. I've got Councillor Kendrick and then Councillor Makinson-Saunders. Then I need to close the debate down.
Thanks, Chairman. Actually, my question was going to be about the potential for training facilities for dentistry in Lincolnshire, but I believe that's been answered, so I'll save you some time.
Thank you, Councillor Kendrick. Councillor Makinson-Saunders.
Oh, I was going to ask about something similar, but we've got plenty of space at Louth if you would like to bring your dental institution over, and it's very good Royal brand as well. I was going to say that I run a baby bank in Louth, and I went out and bought 50 children's toothbrushes recently. I'm rather hoping somebody will give me 50 tubes of toothpaste to go with it. But when we're talking about education, we don't actually teach people how to clean their teeth properly and effectively. And if there are leaflets that we could give out and things like that, because once parents get into the rhythm of children going to bed, but clean your teeth before you go to bed, your job is going to get a lot easier. And I do think we all have some personal responsibility. We can't always point the finger at somebody else. We've got to go halfway to meeting that. And I think there are tricks that we could, I know that's not going to solve the problems completely, but I think the sooner you start imprinting on children's minds, this is what you do and this is the rhythm of life, it does help. And I think you were saying that really earlier, weren't you?
I was. I'm going to answer one part of that question, then pass you over to Lucy to answer the second part. What we visualise the Centre of Dental Development is doing is being a hub and spoke system. So we have the main part of the training perhaps in Lincoln, if that's where we're going to site it, but to have spokes throughout the county, so to hopefully Mablethorpe, Skegness, that way Louth, Sleaford, we're not just focusing in one area, we're looking at a hub and spoke model, really. And I'll pass you to Lucy.
Thank you, Kenny. I was going to come in a bit later on about the toothbrushing packs, so we could maybe pick a conversation up offline, because it is something that we provide through our Oral Health Alliance group in Lincolnshire, so I'll make contact with you about that.
Okay, thank you. In which case, I've just got one question I'm going to ask, because I think you've sort of alluded to most of everything now, so I'd thank you for that. And that is, on page 45, the third bullet point, the report mentions the offer of a golden hello for recruitment purposes. If dentists accept this, how long would they have to offer their NHS services before going completely private, potentially?
Yes, in terms of the golden hello and the scheme, actually it's over a period of 5 years. So if they were to leave within that 5-year period, there's a rolling scale of that the golden hello would be repaid back to the NHS. So we are trying to get that commitment at least for that 5-year period as part of that incentive.
That's good to know, thank you. In which case, I am going to move to a proposal. And that's firstly to thank our presenters for their attendance today. I think it's been incredibly useful, and a lot has been picked up upon, and your answers have been excellent, so thank you. And that the NHS Lincolnshire Integrated Board and East Midlands Commissioning Team report to us again in early 2024 on any further developments on the commissioning of NHS dental services in the East Lindsey area, the development of the implementation plan for the 4 pillars of the Lincolnshire dental strategy, that this committee also supports the concept of a dental school in Lincolnshire, and that we write to our MPs requesting for their support moving forwards on this. So that's my proposal. Do I have a seconder? Thank you. Councillor Linda Wootton. All those in favour, please show. Thank you. That's supported unanimously. And once again, thank you for your attendance. Councillor Morgan, very quickly, because I want to be moving on to the next item.
Yes, thank you. Councillor Cleaver made a proposal which I would happily second, which is that we also, as an authority, write to the government or perhaps local government association and work with them to lobby the government for improvements in the dental practice. I think that's really important that although we're going through our MPs, I think it's important as a local authority that we shout loud and clear about this issue.
I think, yeah, I mean, I could put that forward potentially, but I think it's enough with where we're going at the moment. We're going to have it back in 2024, and we consider it at that point, and I've moved the recommendations we voted now, so thank you. Okay, in which case, once again, thank you for your attendance. You're free to go should you wish, or if you want to stay on for Lucy's item. In which case, I'll move on to item 6, water fluoridation. This item was circulated as part of the agenda pack on pages 51 to 56. The committee has been made aware previously of the benefits to oral health of water fluoridation, and this item provides an update on the latest position. So, Lucy, I'll hand over to you. I think we'll take the report as read, and if you just want to, whip through, and we'll take questions at the end.
Thank you, Chairman. So, yeah, absolutely. The purpose of this paper is to update the committee on the latest evidence around water fluoridation, some recent changes to legislation that came in last year, and just a very brief update on the current situation in Lincolnshire. And so I guess we're switching our focus, if you like, from more of a focus on treatment and care with absolutely important preventive elements to kind of something that is firmly population level prevention for oral health. And we know that oral health is an integral part of our overall health and well-being. Many people, in fact most people, as Kenny said, are at risk of developing some oral disease, tooth decay, gum disease, things like that, during their lifetime, but it is almost entirely preventable. So in terms of the latest evidence on water fluoridation, we know that the use of fluorides, and that could be through fluoridated drinking water, but also through the toothpaste that we use, for example, has a strong protective effect against tooth decay. Fluoride is actually a mineral that occurs naturally in the environment, so it is found in drinking water, seawater, certain foods. And so when we're talking about a water fluoridation scheme, we're talking about where fluoride has been added to the water, to the drinking water, to bring it up to a level that's around about 1 milligram of fluoride per litre of water, which is a level that's evidenced to reduce tooth decay. And it's the Water Industry Act that provides the legal basis for fluoridation schemes in England. We know that having an appropriate level of fluoride in drinking water can reduce both the number of people that experience decay and the severity of that decay, and that's across both adults and children. So just as a couple of examples, the number of 5-year-olds who experience tooth decay is much lower in areas with fluoridation compared to non-fluoridated areas. Children and young people in areas with fluoridation are less likely to be admitted to hospital to have teeth removed due to decay. And adults living in fluoridated areas retain more teeth compared to adults living in non-fluoridated areas. The Office for Health Improvement and Disparities, who are part of the Department of Health and Social Care, report regularly on the health effects of fluoride on people living in areas that are covered by fluoridation schemes. And the most recent report, which was published a couple of years ago, supports findings over quite a longer period of time that water fluoridation at the levels that's recommended for use in the UK is a safe and effective public health measure to reduce dental caries and inequalities in dental health. So just briefly then touching on the changes in legislation. Until last year, it was local authorities who had the responsibility to propose new or to terminate or change existing water fluoridation schemes. The Health and Care Act 2022 transferred that power to initiate new schemes or to change the ones we have to the Secretary of State for Health and Social Care. And the rationale for that change is set out in the paper, so I won't go into detail on that. To move any kind of proposal to develop a new scheme forward, what what would have to happen is there'd have to be a feasibility study, so you'd have to look at whether or not a proposed scheme is operable, and there's lots of kind of technical elements to that. There might be capital investment required to set up a new scheme, and lots of considerations around planning permission, environmental protections and things like that. And the whole process can take several years, so it's worth noting. But under the Health and Care Act 2022, the Department of Health and Social Care would pay for the capital costs and the revenue ongoing of water fluoridation, and it would be the Secretary of State for Health and Social Care who makes that ultimate decision in terms of fluoridation schemes. And it's also worth noting the Secretary of State would have to carry out public consultation before deciding to introduce a new scheme. So that's where we are in terms of moving forward. And then just finally, currently in Lincolnshire, so around 250,000 people in Lincolnshire are supplied with artificially fluoridated water in the central and western parts of the county, and Anglian Water provide that fluoridated water. There are some temporary changes at the moment. So Anglian Water are currently building a strategic pipeline to be able to move water all the way down through Lincolnshire and into Norfolk. The construction work is aiming to minimise the downtime. So effectively what's going to happen is for a really short period of time in a small part of our fluoridated part of the county, the fluoridation will be turned off, but we're talking a matter of weeks. So it will be a short-term impact. Just whilst they're transitioning from one dosing setup to another. And at the end of the programme, so once they finish that work, there'll be no change to the existing fluoridated area, so it will be back how it was before the work started. So all areas currently receiving fluoridated water will continue to do so. And I will pause there for questions.
Thank you, Lucy. Perfect. I've got Councillor Smith first.
Thank you, Chairman. Going on further from what Lucia said, I know that's a relief to many of us. I know when this first came to committee, we were not sure how long the areas that have fluoride would be without it and if they'd ever have it again. So that is a huge relief, to say the least. Further on from that, Chairman, with the change in legislation, would it not be worth us writing to the Secretary of State to see if, through his good office, they are willing to consider having the other part of Lincolnshire fluoridated and considering a study? As my old man used to say, if you don't ask, you don't get. So, Chairman, I'd like to propose that we write to the Secretary of State and ask that a study be conducted as soon as possible so that the whole of Lincolnshire can be fluoridated for the benefits that have already been outlined.
Yep, no problem, thank you. I've got Councillor Allen next, please.
Thank you, Chairman. I'd just like to support everything that Councillor Smith has just said. It's quite clear that the benefits of fluoridation exist and are quite considerable. I'm sure if a cost-benefit analysis was done, it would be easily to justify the capital costs in terms of doing the fluoridation, in terms of the benefit that would come from reduced tooth decay. It sounds as though I don't know which local authorities are involved, whether it's the county or the districts, in terms of promoting schemes prior to 1922. To the 2022 legislative changes. But it does sound as though it was quite a difficult task anyway to go about it. If the Secretary of State has now got the responsibility and has got an easier task in terms of doing it, I agree exactly with what Councillor Smith has said. Can we bring pressure to bear on Secretary of State to actually do the obvious, which is to bring fluoridation to the rest of the county?
If I could just come back on the sort of return on investment, we do estimate that over a 5-year period, for every £1 spent on a water fluoridation scheme, it would return around about £12 of benefit in terms of the health benefits. So it's a sizable return on investment.
Thank you. I've got Councillor Cleaver. Did you express?
Thank you, Mr. Chairman. I suppose I was going to say exactly the same thing that has already been alluded to by Councillor Smith and Allen, that we've discussed this a number of times here. I think there's a great willingness across the committee that we encourage all those, not just actually the Secretary of State, but all those who need to be involved in getting the decision made to actually just get on and do it. Thank you. And I'd just like to thank Lucy. It doesn't go without notice that all the papers we get at this committee that come from our own public health service in the county are always very thorough and very good. Thank you.
Thank you. I've just got 3 questions. So my first is, would it fall to the local authority to undertake a feasibility study for fluoridation, or does a local authority need to persuade the Secretary of State to commission one? I'll let you answer that first and go on to the other.
So it would fall to the Secretary of State, but we work with colleagues in the Regional Office for Health Improvement and Disparities team to effectively, in the same way that you might write to an MP to talk about, to share why we think it's so important that we focus on Lincolnshire. So, but it does ultimately fall to the Secretary of State.
And do you know the level of the priority the Secretary of State gives to water fluoridation and how many new schemes have been agreed in the last 12 months? or have been in turn stopped?
So as far as I'm aware, no schemes have been terminated or stopped. There is an active team within the Department of Health and Social Care who are looking at new schemes. My understanding is that they are intending to start with the North East, who have been very vocal locally in terms of the need for broader water fluoridation schemes in that part of the country. But knowing that the North East have been very vocal, one of the things that we have been doing locally is working with North and North East Lincolnshire, who are also supplied by Anglian Water, and also Norfolk, just to understand from an Anglian Water as a provider perspective whether there's work that we need to be doing. Obviously that crosses regional boundaries, but it would seem to make sense given the understanding the feasibility of how these things work for us to have that conversation en masse around Anglian Water's provision.
And my final question, do the findings of the National Dental Health Monitoring Reports lead to a conclusion that fluoride in toothpaste is not sufficient on its own as a preventative manner?
So it's part of a constellation of activities, if you like, that we need to do to protect our oral health. There are additional benefits to toothbrushing that you don't get from fluoride around kind of protecting gums, keeping gums clean. But also what we do know is that not all people brush their teeth regularly. Not everybody uses fluoridated toothpaste. So they work well together. One of the advantages of a fluoridated water supply is it will protect, it will kind of provide some fluoride protection for people who don't brush their teeth.
Okay, thank you. In which case, I'd just like to... you got one question. Okay, I'll bring in Councillor Makinson-Sanders and I'm going to close it down.
I know in East Lindsey we've been trying to get our water fluoridated or whatever since the last century, and we've never actually succeeded. With our levels of deprivation and lack of dentists, it's pretty important. Would it help if we as a district council wrote letters to the MP, or do we write to you? How do we support you to push this forward for an area that really would like it?
Yeah, thank you. So I think as Councillor Smith suggested earlier, sort of that writing to your MPs and kind of putting forward the case for why it's so important, particularly across East Lindsey, Boston, South Holland, where we don't have water fluoridation, we do see the highest rates of decayed, missing and filled teeth in our young children there. Fluoridation isn't going to be a magic bullet that fixes everything, but it would be a really positive step in the right direction. So I think that writing to MPs would be helpful.
Thank you, because we have a partnership now and the 3 areas are within our partnership, so we'll give it a good old push. Thank you.
Yeah, thank you. In which case, I'm going to move to a proposal, and that is that the evidence in relation to water fluoridation and oral health and the changes to legislation on water fluoridation schemes and the current situation with water fluoridation schemes in Lincolnshire be noted, and that the committee and I as chairman write to the Secretary of State requesting fluoridation throughout Lincolnshire. I also think we should be writing to our MPs to ask them to support that position from this committee, and also our district colleagues, council colleagues, so that we have a unified response, and perhaps between Lucy and Simon we can come up with something that provides that evidence to try and get them on side as well. So that's my proposal. Do I have a seconder for that? Thank you, Councillor Smith. All those in favour, please show. Thank you. That's supported unanimously. Thank you all. Thanks, Lucy. In which case, we'll move on to the next item. So it's agenda item 7, mental health rehabilitation, Ashley House. This item was circulated as part of the agenda pack on pages 57 to 113. In February 2023, the committee, as part of its response to the consultation, accepted the arguments in support of the community rehabilitation model and the permanent closure of Ashley House. The committee also commented on the importance of continuing to monitor the level of need for inpatient services, and also wanted to be advised on any plans for the future use of Ashley House's premise. I'd now like to welcome our presenters. We've got Chris Higgins, Director of Operations for the Lincolnshire Partnership NHS Foundation Trust, Pete Burnett, Director of Strategic Planning, Integration and Partnerships for the NHS Lincolnshire Integrated Care Board. And if I can hand over to you and ask you to present the report in about 5 to 10 minutes and take questions at the end, please. Thank you.
Thank you. Yeah, I'm pleased to be here this morning whilst to present the outcome of the consultation on the closure of Ashley House and the remodel of our rehabilitation service here in Lincolnshire. So councillors will be aware that back in last year, we came on a couple of occasions to update the committee on proposals and changes that were happening throughout that rehabilitation pathway within the trust. So just a little bit of context is that prior to its temporary closure in 2021, the trust was operating 2 wards, Maple Lodge at Boston, a 15-bed unit, and a twin unit in Grantham, Ashley House, that were offering the same service, low dependency rehabilitation care, which is the last stop before people are admitted into the community or discharged into community with community support. We temporarily closed the unit in 2021 on the back of in response to COVID pandemic and the pressures that we were experiencing at the time on staffing, and that allowed us to expand the community rehabilitation service from what was just operating in the west of the county into a slightly larger geographical area to support the patients that were previously at Ashley House. We've done an extensive amount of engagement work over that period, both with staff, patients, carers, and wider stakeholders, and that's been really positive, both in terms of experience that people have had of the new way of working, care closer to home, and in terms of patient outcomes, clinical outcomes that people were experiencing. You'll see those in the report. We've got quantifiable clinical outcomes that are demonstrating the benefit of that community model. It's also worth saying that that more community-based model is in line with the NHS direction of travel to support people closer to home. It's also in line with mental health direction of travel, which is trying to, again, support people close to home, but in the least restrictive way possible and maximising independence. And you'll see again in the report that the themes that were coming through from engagement were that people wanted to be supported at home wherever possible. And we've really tried to strengthen that offer through the work that we've been doing. So as has been introduced there, we came to committee in October and presented the findings of that engagement and a proposal to engage in a formal consultation process that we subsequently carried out between January and March of this year. And you'll see again in the paper that that's been quite extensive with the numerous different ways to engage people that might find this an area of interest to them, including patients and staff that use and are familiar with the service. We've now considered all that feedback and also engaged as part of that process the East Midlands Clinical Senate for an independent review of the proposals. And again, you'll see in the papers that we've taken on board those recommendations and provided an appropriate response. And there's work ongoing, as you'll see, that we're committed to model and monitor the future impact and need across the system. Having considered all that and the robust consultation process and the engagement that preceded it, LPFT's board of directors made a decision at the end of last month with support of Lincolnshire ICB to progress with option 2, which was to permanently close Ashley House in favour of expanding the community rehabilitation service to a county-wide model. So we're asking the committee today to note the consultation that's taken place in line with what was agreed previously with the committee and also the decision that's been taken. Just a couple of things that's worth pointing out. One is that as was the case back in October when we spoke to committee previously, and has been the case since 2021, anybody requiring that level of care, that low dependency rehabilitation, inpatient care, have been able to be admitted to Maple Lodge. We have continued to have and continue to have appropriate bed capacity and availability for when people need that level of care. But what we've seen with the community rehabilitation team is that expanded offer is allowing us to support more people at home, so there's less people that need that care. You'll also see that one of the key features that came through previous engagement and the consultation was about people's transport to access care. Obviously, some people are having to travel further than they would previously, particularly those in the Grantham and surrounding area. Worth pointing out that overall, there's a significantly higher proportion of people that have to travel less, but we do recognise that some people, a small number of people, have to travel further. And as a consequence of that, and listening to the feedback that we've received, we've now drafted up a operating protocol that will allow us to pay travel costs for people that are placed further away from home, and we're monitoring that on managing that on a case-by-case basis. But we're committed to making sure that people aren't disadvantaged, certainly financially, if they have to travel a bit further to access care than they would normally do so. It's also worth saying that we, through the Clinical Senate, we agreed and committed to doing ongoing assessment of demand, and we're working with system colleagues through the ICB and others to model current and future bed requirements, recognising the changing population profile over the next coming few years. And so again, we're just modelling through that and review that annually as part of our annual business planning process to make sure that we've got sufficient bed capacity and other services to support the needs of the people of Lincolnshire. So we're at a position where I'm really pleased to be here. This has been a long journey in getting here, but it's a really good way of working. It's modern ways of working and supporting more people to live well in their communities, which is what we're really striving to do. I'll hand over to Pete now just to give you a bit of perspective from an ICB viewpoint, but happy to open up to any questions that the committee might have.
Well, thanks, Chris. There's not much to add, really. I think the key, but obviously the ICB and LPFT have been working closely on the consultation development of the kind of proposal as we've gone through. And I think the key here is that it's what's the decision that's been taken is in line with the NHS England's long-term plan for mental health services and their kind of dedicated community mental health rehabilitation function that they highlighted back in 2018 in the long-term plan. And we'd had the pilot in the west of the county, and this decision allows us to expand that pilot and provide those services in people's homes, where evidence shows that obviously the best rehabilitation is, because that's what you're trying to rehabilitate them to be back in the community and living their own lives in that way. And this provides that service to them, and with the support of their kind of close communities and families and carers might be alongside them at that point. So yeah, we're very supportive of it. The key going forward, as Chris says, we're going to do the demand capacity modelling, and obviously we'll keep a review of that. We'll also continue to further engagement with patients and their families involved in the service, just to make sure actually we're getting it right, because although the decision's been taken today, we need to monitor that and collectively do that together to make sure actually is there any tweaks, is there any changes we need to make going forward. But we do think this is a positive step in line with the national direction, in line with the direction we want in Lincolnshire, where care is provided close to home, and I think we feel it would be real. This is going to be lead to real tangible benefits, and has already to the patients that are under this service.
Okay, thank you both. First speaker is Councillor Morgan.
Thank you very much for that. Can you just give us an understanding of what would trigger somebody moving from care in the community, being supported in the community, to actually needing to stay in our low dependency unit, just to try and understand what the difference is and the potential impacts any changes may have to that person.
Councillor Morgan, would you just pull your microphone a bit closer to you?
Sorry. Do you want me to repeat that, or you're all right there? If I just ask that first, if I may, thank you.
Yep, thank you. So the low dependency rehabilitation unit sits, or offers, sits at the end of our kind of pathway of care. So often people, it's unusual people to admit there directly. Often they're admitted to other forms of support, either an acute mental health unit because they've got an acute crisis happening, an acute phase of their illness, or they've been in longer term rehabilitation care. And it's a step down approach that this will be the last stop before community. Some people are admitted there just for a kind of a short length of stay sometimes, but more often, and most often, it's those people coming through that pathway. And what the community rehabilitation team's enabling to happen is that more people can step straight into community, or if they do need to go into that low dependency rehab, they can go through Maple Lodge and they can step out more quickly than they would have been able to before. Prior to the community rehab team being in place, there wasn't much in terms of that offer of support. It was kind of routine appointments, fortnightly or weekly for people through our kind of standard community mental health teams. But the community rehab team is able to offer really intensive support daily, sometimes several times daily, 7 days a week, so that we can really offer that wraparound care and allow people to step out much more quickly than they would otherwise have done before.
Thank you for that. Then the follow-up question is how are we able to support the level of demand? Do we actually have enough resources in that area, given it is so important? Just if you could answer that, please.
Yeah, so what we've done over the last couple of years is really detailed modelling work about how the flow of patients are coming through, making sure we've got appropriate bed stock for those that do need to be admitted. But what we're seeing with that community rehab offer, and we'll see it expanded when we expand it further, what we'll see is less people needing that hospital admission. Now, what we can't predict necessarily is what will happen in the next 10, 15 years in terms of population demographics, but we are doing some work around that to build some assumptions and some scenarios that might happen that might indicate what we need in future years. But certainly for the here and now, there's adequate bed provision to meet all that need, and that's likely to be the case for at least another 5 years. What we're seeing across other pathways of care and rehab here in Lincolnshire and beyond is when you've got really robust community services in place, you can really keep people out of hospital really well, and it's just that intensive level of support can keep people out of hospital in a really appropriate way, in a way that meets their needs and the way that people prefer. So we'll watch that over time, and what we might see, we might have to bolster those community rehabilitation services in time, but certainly for now we've absolutely got enough to meet the current and expected demand over the next few years.
Councillor Kendrick.
Thank you, Chairman. I see there's going to be an option appraisal on the future of Ashley House. I don't know if you can give us a time scale as to when you will come up to a result on that one. And obviously, as funds will be shifted from Ashley House to adult community services, I'm guessing that depending on what is decided for the future of Ashley House, some funding will be required for what services may be delivered there in the future. Thanks, Chairman.
Yeah, so Ashley House is a trust-owned asset, sits within our mental health site in Grantham. So whatever we do in the future will be supporting mental health, learning disability and autism care in line with the trust's business. And so in terms of timeframes, we've not nailed that down specifically, but probably by October we'll have something, October, November time, an options appraisal done on that unit. There are a number of different options that we're looking at, from community hubs to be able to do step-down support for people with learning disabilities to other mental health services. And we just need to look at the range of options, working with our council colleagues, ICB colleagues and others in the system about what's the best use of that unit. But I can be confidently say that whatever we use it for, it'll be something to support that mental health, learning disabilities agenda, because it's on our site and it's something obviously that's really important to us.
Thank you. Councillor Allen.
Get it on in the end. When it came through to us some time ago, it did seem to be a sound idea that was being put to us. It was to make a better use of valuable resources within this field. And I'm very pleased to see that a number of the comments that we made that were reported back to our presenters have been actioned or have been taken forward as part of the initiative. There's just one question, I think, which might be, from my point of view, useful to have a response. And this is to do with the sort of out-of-hours situation. Because I think the point we made last time was that not every patient probably has got full support from family, which would be very, very useful when they go from a community point of view, or health provision point of view. So the out-of-hours service might be quite useful in some circumstances, and I just wondered how that's going to be dealt with. Or is it a question of identifying those sort of issues early on and providing a position within the remaining hospital unit?
Yeah, great question. I think it kind of links back to one of the previous questions, is that it's the tipping point that somebody needs admission. If we feel that a person can't be supported with that really intensive support between kind of the hours of 8 and 8, that's probably the point that somebody would require admission. But what we're finding is the majority of people with that intensive support certainly can manage their conditions and manage their needs in that time. But that is supplemented by an out-of-hours crisis team that operate 7 days a week, 24 hours a day. So if somebody out of hours did feel that they were struggling, getting into crisis, there's a 24-hour helpline that's in place now, and also our crisis teams in place that can offer professional support in that area. So I suppose that's the key point, really, that if somebody wasn't able to cope with those services that are in place, that's probably an indication that somebody needs an admission, and we would make sure that that's available to them.
Thank you. Very, very quickly. Thank you very much for the response. I'm very comfortable with what you said. I would just like to say it seems to be a very well thought through proposal that's gone through consultation quite successfully and ought to be supported by the committee.
Thank you, Councillor Allen. I've just got one question myself, and that is 1/3 of the staff responding to the consultation preferred the option to reopen Ashley House. Was this level of staff support for retaining Ashley House expected?
Yes, in part. And so if you look at the numbers of people that responded, and I think overall you'll see that there's quite a low number of people that responded because it's quite a specific service affecting a small number of patients and a small number of staff. And so what I'd say within that, there were staff included in those comments that were people that previously worked at Ashley House who have been, I suppose from their perspective, have been moved to different units, and so they had a particular affinity to Ashley House, and so that was within there. But also what we did identify through our people committee, our workforce committee in the organisation, is we need to do some further work with staff to really help them understand what the unit's about, particularly those teams who aren't directly involved with that. So some people were seeing that they're worried, like are concerned that, like the councillor mentioned today, about is there enough beds? And yes, there is. We've got evidence over the last few years that there is enough beds and will be in the future. And so there were just concerns around that, but it's a more of a education and explanation piece for that small number of staff that were a bit concerned. And our board committees and then subsequently our board were convinced and confident that through engagement with those staff groups that they will be able to satisfy their concerns.
Brilliant, thank you. In which case I haven't had anyone else express any interest in raising a question, so I'm going to move to the proposal, and I propose that the outcome of the mental health rehabilitation consultation conducted between the 16th of January and 31st of March 2023 and the decision by the Lincolnshire Partnership NHS Foundation Trust with support from NHS Lincolnshire Integrated Care Board to permanently close Ashley House in Grantham and extend the community rehabilitation service county-wide model be noted. I also propose that an update be requested in 1 year's time on the implementation of the community rehabilitation service model, including monitoring of any areas, monitoring of out-of-area placements and any data on projected future need for inpatient beds, and also that any proposals for the future use of the Ashley House premises be shared with this committee. Do I have a seconder to that proposal, Councillor Allen? All those in favour, please show. Thank you, that's supported unanimously, and thank you to Pete and Chris. We'll now move on to the next item, which is agenda item 8, Adult Mental Health Services. The report is found on pages 115 to 130. Last year, the committee held a working group which considered various aspects of mental health provision, and as a result has requested an outline of the various new developments. Next month, we are planning to look at the remaining 2 services, children and young people and older adult services. I'd like to welcome our presenters from the Lincolnshire Partnership NHS Foundation Trust, Chris Higgins once again, Director of Operations, Nick Harwood, Associate Director of Operations, Adult Community Division, and Paul Jelly, Associate Director of Operation for Adult Inpatient and Urgent Care Division. If I can hand over to you just to sort of whip through the report again for 5-10 minutes and take questions at the end. Hopefully you're all here at this point because I'm just aware we're slightly ahead of schedule.
Yep, thank you. Yeah, we're all here. So pleased to be presenting this paper. I know it's an area of interest for the committee, and hopefully what we can go through now is a bit of a short update of the highlights. Obviously, you've got the report yourselves, and then we'll open up for questions. So I won't dwell. I'll hand over to Nick and then over to Paula, who can give you a bit of highlights, and then we can go for questions from there.
Thank you, Chris, and thank you, Councillor Mason and the committee for giving us the opportunity to talk to you today about some of our updates. So yes, I'm Nick Harwood, the Associate Director of Operations for our Adult Community Division. Our division covers a range of mental health community services, and they're described in the appendix of the paper, so I won't go into too much detail, but just as an example of the services that we've got the talking therapies for anxiety and depression department, our community mental health teams, perinatal mental health. We've got the mental health social care sitting in our division, which is a Section 75 agreement with the local authority to deliver mental health social care, and early intervention in psychosis. But some of the other services will come up as I continue with my talk. I was asked today to talk a little bit about the community mental health transformation, a programme that's been going on for us now just over 3 years. We were one of 12 early implementers. So a little bit of a head start in terms of the rest of the kind of country. So we've learned an awful lot in that time. The focus of the programme really is around severe mental illness, although we are, entirely focused on the wider implications of mental health well-being in our county. It's a very ambitious programme, NHS England driven, with quite a considerable roadmap. I'd be happy to share that if people wanted to see that, but an awful lot that we're expected to achieve over the next few years, and already have achieved quite a lot of. Some of the basic principles really are around things like no wrong door, so that people with a mental health problem, wherever they present, we need to be reactive to that, not the traditional everyone needs to see a GP type approach. No cliff edges. It's really important for people to, when they access services, that they feel as though they've got places to be stepped down to, that there are opportunities in people's communities for them to, live their most fulfilled lives. And co-production is really at the heart of this programme. So listening to people with lived experience and their experiences and building our kind of work programme around that. Some kind of core things that we have to do. We've got to move to a 4-week wait, which is quite a challenge, but one we're up for. But that's a big change. Previously, the targets were around 18 weeks. That's quite a shift. So some work to do around that, and outcome measures, making sure we're really clear on the interventions that we're providing and how they are supporting people. Very much a whole system approach with all of our partners involved. Mental health needs to be and should be everybody's business. It's not just that of the mental health provider. You'll see in the paper an inverted triangle, which tries to describe the sort of model that we're working towards. And it really pulls together 3 key elements, which is that voluntary community and social enterprise sector, our community kind of assets, our relationship with primary care, and what we're going to be left with, what we're going to do as a secondary mental health provider. I think to date, we've tried to do everything in many ways, and the demand's huge, and resources have not kept up with that. But with the investment in this programme, hopefully we've got some real traction around that. So in terms of that community assets kind of area, we really need to ensure that people have got meaningful alternatives to secondary mental health care, and that is activities and opportunities for people in their communities. It's been a bit sporadic in the past based on limited funding parts, but we've made sure we've put significant amount of the investment in this programme into that third sector, and that it's everywhere. I think in the past we've been able to fund things in Lincoln and Boston and the bigger towns, but this is about ensuring that equal investment is within the whole county. If people get the opportunity, we've set up a new website called How Are You Lincolnshire, which details all the programmes and projects that we've got out in the communities. So a really good place to see the level of investment and the activity that's now being delivered out there in people's communities. We've set up community hubs in each locality, places for people to drop into, places to be part of a community, and employed a new group of staff called community connectors, who are there. The third sector often can be, one man doing a man's group out of his shed, but how do they feel connected to each other and have a voice? Stronger together, I think, is the principle around that. And sustainability. We don't want the third sector organisations to come and go. We want them to be part of our options for the future. Social prescribing link workers, another new role that we've brought in, sitting with their social prescribing link workers in primary care, but also as part of our teams, so specifically focused on supporting people who need that hand holding into those community provisions. I've just spoke about what we're calling a mental health and wellbeing community investment fund, quite a mouthful, but we've invested around £1.5 million in that in this year. That's the level of investment and commitment that we've got to the third sector. We've employed peer support workers in our communities as well, people with lived experience who got that knowledge of the services, understand what it's like to be a service user in our services. And a real success, our nightlight cafes. We started with a handful in Lincoln a couple of years ago, run by one of our third sector organisations, and we've now expanded that out to the entire county. At last count, I think we've got over 25 cafes operating in Lincolnshire, so a real success there. In terms of locality mental health, so we're working towards operating out of our localities in a slightly different way, aligned to our primary care networks and really strong relationships with primary care, really focused on population health. Our populations in Lincolnshire are different, and I think long gone are the days where we try to apply a national model to everywhere. It is about localities and what people need within them. A range of professionals working in those spaces. Really important part of the kind of puzzle really was to ensure we've employed staff into primary care. And at last count, and we're recruiting all the time, we've got 24 senior mental health professionals working in primary care directly with GPs and other colleagues in primary care to be that front door, that first port of call for people with mental health problems, with the expertise and link back into the mental health trust to get people to the right place first time. In terms of our specialist services, I really want our community mental health team, part of that locality kind of footprint, part of that puzzle really, to be, they are specialists, but enhancing that speciality in the things that they deliver, being very intervention focused, ensuring that we're offering the right psychological therapies and that people are getting access in a more timely way. And some of the service we've been asked to provide, if we didn't already, and you've just heard about community rehabilitation, is one of them that's in the roadmap, alongside services for people with personality difficulties and complex trauma, ensure we've got appropriate services for them. An expansion of our adult eating disorder service. We've seen quite an increase in those related issues during the pandemic, and that stays with us. And ensuring that we continue to deliver on our early intervention and psychosis services and employment opportunities for people. So again, really important. I was asked to talk a little bit about transitions between our services. That's a really important area that can be a cliff edge for people when they move between, for example, children and young people services into adult services, or adult service into older adult services. So my colleague, when she comes next month, is going to talk in more detail about this as she manages the children and young people services. But I just wanted to make the point really that in the past and still presently, we've kind of got them cut-off points related to age. However, the future looks a little bit different to that. We need to be making sure we're making needs-led decisions based on the best fit and the best place for people to be. So blurring those boundaries around age limits, and I think that's the right thing for people. Similarly for older adults, we don't transition people to older adults if they've still got needs that could be met by our services, but people presenting over the age of 65 with the first episodes or with dementia or memory related problems, we have specialist services for them. And of course, the transitions are also important for people who've been in our inpatient units and under our crisis teams, where they've had intensive support back into the kind of less intense support we offer, so ensuring we're covering those bits off. Final bit that I was going to talk about was just around waiting times. I know that's an area that people are often very interested in. I often get asked, what's your waiting time for a specific service? It's very difficult to answer because there's often a range of interventions that are offered within teams and services. But it's fair to say that we've got pockets of challenged waiting times, where we've kind of got shortages of staff, etc. We do struggle at times to meet those waiting times, but generally we do very well against the 18-week standard, and we're moving towards that 4-week standard that I spoke about. And we are in line with the national picture on that currently. And I know another important area is, what do we do with people while they are waiting for services? So we're very keen, and we make sure that we stay in touch, that people know what to access in a crisis, who to access if more urgent support is required. And we do have a duty system in all of our teams that is accessible to everybody in the service and waiting for the service, and people are given that number, as well as some self-help material, things to be working on while they're waiting for our services. In terms of our Lincolnshire Talking Therapies department, there are national waiting time standards around that, which we do achieve. But more importantly, we make sure we monitor very closely the internal waits, the waits between services. And they're variable. Again, it's difficult to say the waiting time is X amount of days. There's around 8 or 9 different therapies offered out of 9 different teams. So quick maths, up to 81 different waiting lists, but we monitor them very closely. And our specialist services around perinatal, early intervention and psychosis don't tend to have waiting lists. It's important that they're accessible really quickly when people need that. So I'm going to stop at that point and hand over to my colleague, Paula. Thank you.
Thank you very much, Nick. Thank you, everybody, and thank you, committee, for the opportunity just to come along and update you with things that are going on within inpatient and urgent care division. So this is my portfolio, and we've had some significant changes, and we've had some really good services coming on board over the last 12 to 18 months. So really looking forward to seeing the outcomes of those. But following on from our work around the eradication of dormitories, we're really pleased to announce the opening of our new wards last month, Castle and Ellis. They're now providing a 19-bedded individual ensuite bedrooms to our patients with a really improved ward space, lots of outdoor safe areas for people to access freely. So our patients have been giving us some early feedback, which we've been taking on board. It's been really positive. They've all settled in really well into their new environments. It was a really collaborative piece of work, and we involved our patients, our carers, our expert by experiences, and our stakeholders to ensure that we built the accommodation to meet the needs of the patients that were coming onto our wards. It was really important for us to get that patient experience right and actually provide an environment that was the most therapeutic that we could possibly bring people into. It's really important to feed in and have the the views and the experiences of everybody involved. So we're talking carers and families as well. So really collaborative piece of work, and the outcomes are really positive already. So with that in mind, we now turn our attention to the Eastern Coast, and we're pleased to have recently been given planning permission to build a new design on the Norton Lee site over at Boston. This will replace our Ward 12 acute ward, which is currently sat within the Department of Psychiatry on the Pilgrim Hospital site. We will be utilising some unused land that's currently owned by the Trust, and again we'll be looking at that individual ensuite bedrooms and looking to provide a really improved environment for people that are coming into services over the Eastern Coast. We'll also be taking the learning that we've had over the last kind of couple of years when we've pulled together the plans around the Lincoln site as well. So really looking forward to that. The hub will also be home to our crisis teams as well. So this will reduce the risk of Ward 12 being a standalone service. So we'll be able to offer some internal support from teams. We're looking to continue to finalise those plans as well and prepare the site, and we're hoping to start building from September for completion by summer 2025. So I think this will be a really welcome service to the Eastern Coast as well, particularly within the Boston area, and will absolutely bring us in line with that eradication of dormitory mandate, which we are absolutely committed to achieve. As part of our division, we do have our psychiatric intensive care unit, and the committee will be aware that we made a difficult and emergency decision to temporarily shut the service in November 22 in direct response to some critical staffing levels that had been impacted by lots of different factors, COVID, high vacancy rates, and we were seeing a higher turnover, and we were experiencing long and short-term sickness. However, our plan remains to open on a phased approach in November this year. So we took on a comprehensive programme of work in terms of our workforce and looking at our recruitment and retention of staff, particularly in our inpatient services where we've seen a lot of challenges. So we've been doing some proactive advertising campaigns. So you may see familiar faces on the side of buses and on petrol pumps, and we're really trying to get that out there into a space where we possibly haven't done before. We're also looking at continuing with our international recruitment. That's been really successful for our division over the last 12 months, and we're looking forward to welcoming several more international recruits onto our wards over the coming months. So really happy with the way in which that campaign has gone, and they've brought so much to our wards as well. We're learning an awful lot from our international recruits, so it's been a really good supportive two-way offering. And as part of our future-proofing our workforce, we are looking at growing our own, so looking at supporting apprenticeships and nurse training in the future, and also looking at the skill mix that we have within our, our current staffing mixes at the moment. So what new roles can we bring on board? What can we do to complement the roles that we've already got, but also, a real appetite to look at doing something different so that we can have a different result and really secure that workforce for the future, particularly in inpatient services. So one of the roles that we introduced over the last year was a carer champion role. So this was developed, directly with carers and families to offer direct support to our carers whilst their loved ones and their family members are staying with us in inpatient services. And it was to enable carers to have a consistent person to contact. They will support carers while their loved ones are on our wards, and that will mean reaching out to our families and also supporting them with being really actively and thoroughly involved in care planning going forward, so supporting our carers to attend multidisciplinary team meetings, really being involved in the care planning of their loved ones. And we've received some really positive feedback about those new roles, and we have had carers say it's been a real support to them through a really challenging time. There's a lot of anxiety for our families when loved ones are coming into hospital services, and we also need to make sure that we're getting that discharge planning right. So really linking our carers champions in with NIC services within community teams as well, and really helping to develop those discharge plans and making sure they're as robust as possible. And our carers champions will also stay involved for a period of time post discharge as well, just so there's that continuity of care and there's that person there that they've developed a relationship with. So as a result of the initiatives that we're doing around our workforce and trying to strengthen our workforce, we are beginning to see an improved position within our services, which is really great. So we'll continue to drive those campaigns forward. We'll continue to review and develop our workforce plans, and hopefully we'll see that improved position continue as we move into the latter part of the year and into next year. We've also seen an expansion and strengthening of our urgent care pathway. So this includes support for those that are experiencing a mental health crisis. So as Chris alluded to in his previous, when he was talking earlier on, we do have a 24-hour mental health helpline. That is often the first point of contact to talk to somebody if you're experiencing mental health difficulties. And sometimes that may provide a listening ear, which is enough for some people. And it will also enable you to be linked into community services that are on offer. And as Nick has alluded to earlier on, we are also as a division really committed to working much more closely with our VCSE sector and really linking into that wealth of support that is available within the community. And just to add to strengthen what Nick has said, we are working really closely with our nightlife cafes, and we've had some really good results. However, if it was felt that somebody needed more support, if there was more concerns, then our mental health helpline colleagues, Mental Health Matters, will then put them in touch with our local crisis teams, who will go out and offer some more intensive support for a person who is experiencing crisis. We're continuing to, like I say, develop our relationships and strengthen our relationships with our VCSE sector, but also with our primary care colleagues as well, and in particular our pharmacy colleagues. We've been linking in a lot recently around some initiatives that have taken place within pharmacy services. To further support people in crisis, the Trust also has a mental health practitioner that works alongside our police colleagues in their police control room to give some advice if somebody is presenting with mental health challenges. And we also have crisis response vehicles in Lincoln and Boston, and they're available to go out and respond to calls from the police and ambulance to assist and kind of help with that support around mental health. Again, we've done a lot in terms of expansion of the urgent care pathway, and we took the opportunity to commission a full internal evaluation of our current model of delivery for crisis and home treatment teams. We've done that again in extensive engagement with our stakeholders, patients, carers, experts by experience, staff, and again, the wider VCSE. We're currently gathering all the data around that, looking at the narratives. We are going to be evaluating that, and then we'll be looking forward to to kind of sharing our findings and recommendations once that's completed. So I think with all new services coming on board within the community, it really has given us that opportunity to look at what we're currently providing. Do we need to provide it in the same way going forward, or do we need to look at doing something different? So really welcomed that piece of work. We've also welcomed mental health liaison into the division. So this was a service that used to sit within our older adult and frailty division, but came to join us within the urgent care pathway last year. So they're a service which are based in our 3 main acute hospitals in Boston, Grantham and Lincoln, and they will see people who are attending our ED departments or receiving any treatment on short stay wards and longer term wards to support with any mental health presentations or ongoing assessments and referrals. What we've also done as part of that pathway as well, and again alluding to what my colleague Nick has already spoken about, we are looking at services being respondent to need instead of age. So as part of the mental health liaison offering, we've now brought on CAMHS workers into our team, and they will be able to offer some support to our children and young people, and again build on that philosophy of having an all age pathway that responds to a level of need as opposed to it being by age. And I think for us, the other kind of main development within our urgent care pathway has been the introduction of our mental health urgent assessment centre, so which we refer to as our MUAC. So this was a service that was developed and mobilised relatively quickly to provide a therapeutic relationship environment for those presenting in a mental health crisis, but may not have any physical healthcare needs. So historically, these patients would have presented in A&E departments, whereas our MUAC offers an alternative place for people to receive a really rapid assessment of their mental health needs. But it also provides an additional place of safety in an environment that is really appropriate. It's very calming, and actually, it's an area where we can help facilitate carers and families staying with their loved ones while we undertake those assessments. So initially, it was a pilot that we were looking at piloting for 12 months, and that was using some funding that we were lucky enough to secure through some winter pressure. And that was across the Lincolnshire health and care system. We've already seen improvements in terms of the decrease in footfall in A&E for those in a mental health crisis. But what we've also seen is some real improvements in patient experience. And that's got to be at the centre of what we do in terms of driving these new initiatives forward. And there's a real appetite for us to continue to do that. It's also given us an opportunity to look at some of the health inequalities as well. Many of us know that people in mental health crisis really don't want to attend a really busy A&E department. It can be quite daunting for them and can often put them off actually accessing healthcare. So to attend a more calming environment with mental health trained professionals on hand to support them has been really welcomed. We had a robust independent evaluation undertaken recently, and that was by the East Midlands Academic Science Network. And we're pleased to have been awarded recurrent funding to continue the great work that's already going on in the Mental Health Assessment Centre, but also look now to extend that to an all-age pathway in the future. That will also include children and young people. So again, really driving this, all-age pathway and all-age approach. So now the funding has been secured, we will look to maybe do a relaunch of the service as well, particularly around MUAC. We've taken, probably not, we probably haven't gone out and done a really big, kind of drive on how to access and we're really trying to do that now that we've been given that secured funding. So exciting times ahead. I'm really excited about what the future brings and really looking forward to expanding our services. So I will wrap up there and obviously hand back over to answer any questions, and thank you for taking the time to listen.
Thanks. Just to finish off, I just would say, obviously a lot of work going off, and you'll see from the report and what's been spoken about there. Just to say, I think it'd be remiss of me to say that we don't have challenges, and I know the colleagues have hinted at some of those throughout their presentations, is that things don't go according to plan at times, and we do have issues with workforce, as you know, you'll have heard through previous committee meetings and was alluded to earlier on, that workforce challenge is improving, but it's still significant across a number of teams. It's probably one of our biggest risks as an organisation that the board's very closely sighted on. That impacts on waiting times and ability to respond in the way we'd want to. But equally, as you've heard today, there's a lot going off to really combat that and put alternative services in place so that we can minimise the impact and make that experience for patients and families as possibly as good as possible anyway. So, but yeah, happy to stop there and take any questions.
Okay, thank you for the presentation. I just wanted to commend the new fantastic facility in Lincoln. I got to look around it very luckily, and it's out of the ordinary. It's good to see such an investment into Lincolnshire, and I think we very much so look forwards to it in Norton Least, that we've got something along the east coast for us as well. So, yeah, very good. Right, my first question comes from Councillor Matthews, please.
Thank you very much, Chair, and thank you for your indulgence in letting me speak. I also want to thank you for the changes that are being made, because they are becoming obvious on the ground in my community, which is Mablethorpe, Sutton-on-Sea, Alford. It's very pleasing. My challenge to you is about transition. You mentioned transition on page 121 of your report, but on page 122 of your report, you talk about your urgent care pathways expanding. And I just wonder if it's possible for you to look at how your urgent care pathways can accommodate a pre-transition contact as well as smoothing transition, so that young people who are technically under 18 but rapidly getting there don't get, I'm going to use a phrase, messed around. I'm not suggesting you'll mess them around, but because of the process of transition, you're saying you start to transition at 17 years and 6 months, and then you've got peer support and things like that. And I know you're going to talk about this next time, but I wonder if you could go back and have a really good look to make sure transition is totally smooth, particularly for clients who are problematic in the sense of their community, but also for new entrants to the new entrants through the urgent care pathway. Thank you very much.
Absolutely, thank you, and a really, really good question. So we do have a very robust urgent care pathway, and that does include our crisis teams. We've also got a crisis response within our CAM services as well, and I'm sure my colleague, when she comes to speak later on in the year, will go into a little bit more detail. But absolutely recognise the challenges in terms of the transitioning, particularly between kind of 16 and 18. So again, this is where we're trying really, really hard to come away from, you know, a age-led model and look at a needs-led model. So we do, you know, link in with other services within our own organisation to look at how we can support somebody, and we will always be looking to do the right thing. So we will offer that support. It's really, really difficult, but I think with the expansion, particularly within the Mental Health Urgent Assessment Centre, where we've got access and where we'll be looking for that all-age pathway. So young people in a mental health crisis will be able to have access and have support within a therapeutic environment. The hope is in the future we'll be able to mirror all that down the eastern coast as well. So we do recognise that there are some challenges in terms of conveyances and access to services that feel very Lincoln-centric. So again, in terms of those health inequalities, we're building our services around that modelling so that we can, you know, deliver services within areas where we know there's significant pressures. So we will have conversations, you know, between the divisions to look at, you know, what support is available to people, but we'll also do bespoke ones as well. And that might mean that there's an element of support given by our specialist services and our CYP services, but in conjunction with urgent care services and some of Nick's teams as well. And also tapping into that real wealth within the VCSE sector now around support in the community.
Thank you very much. I think what I'm specifically asking for is that on page 120, you say you're taken the opportunity to commission a full internal evaluation of the current model of delivery. And I'm just asking if you could put in a hard bullet point on that to say, including at the point of transition and for young adults between 16 and 18. You're doing it already. I just would like you to put the spotlight on that transition during that urgent care review that you're undertaking. Thank you very much.
If I can just jump in before you do. I'd just like to ask a question as well, which sort of follows on from what Councillor Matthews is asking. And again, on page 122, the report states that anyone attending A&E at either Pilgrim or Lincoln Hospital can be seen 24/7 by a member of the mental health team. Having had experience of attending late evening on a Friday and a number of weeks later on a Saturday, there were at least 3 people who had been waiting to be seen and who had been told that there would be no one to see them before 9 a.m. the following morning. Subsequently, I've spoken to someone who works in a Skegness-based mental health charity who has also told me that they always advise anyone in crisis overnight to go directly to Lincoln for the exact same reason. Can you respond to these access issues, please?
Yeah, thank you. Yeah, I'm happy to respond to that. So we do know we've had pressures along the Eastern Coast in terms of our workforce. We do have targets in terms of the response time from mental health liaison. Again, in terms of our urgent care offering and looking at a more robust pathway for response times, then we have strengthened our business continuity plans to include support being offered by co-located teams. We are hitting our targets. So for A&E, our target is 80% and we're achieving 93%. However, absolutely recognise that there is more work to be done, and really welcome any feedback in terms of people's experience and how we can use that moving forward. So the offering in Lincoln is the same as it is in Boston, and again, we will be looking, and we do keep an eye on those targets, and that is something that we are held account for, within our own organisation as well. So we will be working and looking at what we can do to strengthen the Eastern Coast.
If I may, Councillor, just to come back in on the end of that, is that we've put additional staff in, specifically Boston, we've put additional staff into the mental health liaison team in terms of children and young people staff that will just add to the capacity of that team, which should help. And you've heard about some of the plans that we're working on. We know it's not quite right at the minute, hence we're doing the review that is picked up in the report, and absolutely take the point about transitions being part of that review. We'll make sure that's included as a core part of the scope of what we're doing. But that review really needs to understand, because we're getting different experiences. That's one of the things that we've identified. We're getting different experiences in different parts of the county, and that shouldn't be the case. We want to make sure it's consistently positive everywhere. So hence the review, and absolutely value the experiences and feedback that we've got today, and we'll make sure that's covered off in the work that we're doing.
Thank you. I've got Councillor Kendrick next, please.
Thanks, Chairman. I was interested in the nightlight cafe thing. Anything else you may not be surprised to hear when the word volunteers mentioned. I'd be interested in that, and I'd welcome the opportunity to actually visit one of these night cafes and to learn more outside this meeting about the training that the volunteers receive. Just a couple of other questions. Sometimes I'm aware that there's a capacity issue with crisis teams. I hope that that's not the situation now, and also how great is an increase in dual diagnosis? I'm thinking of people who have mental health and substance misuse issues. It's been a trend over many years of an increase, and have you the capacity to deal with that? And finally, I'm pleased to hear that at long last Ward 12 is going to be relocated. I remember it many years ago, visiting it on many occasions when I worked for LPFT. It was a totally unsuitable location, and I know there was talk 10 years ago about moving it. It's great news to hear it's finally going to be relocated. Thanks, Chairman.
I'll take the first bit of that. And thanks, Rob. And I would very much expect you to be interested in the volunteer element of the provision that we're now looking to provide. But yes, very welcome to come and attend one of the nightlight cafes. We can organise that and give you an overview of the training. But it is volunteer run. It's the Axe Trust in Lincoln that take the lead, but the cafes are hosted by a variety of third sector organisations. But yes, we do provide training and support for that. But yeah, be delighted if you want to come along and we can organise something to come and have a visit. I'll take the dual diagnosis question as well, which affects all of our services, but happy to speak on that. Wouldn't necessarily say it's an area where we've seen an increase, but it's certainly an area where we've had a bit of an increased focus. So it's really important. Obviously, the drug and alcohol services for Lincolnshire are commissioned separately and through a different provider. And we've worked really hard over the last couple of years to improve that relationship. We do have a system-wide dual diagnosis group to be thinking about the dual needs that this group of people have. Sometimes you can get into some of the what comes first, the substance misuse problem or the mental health problem, but we need to address both. We need to work together on that. We're seeing certainly some discussion about where we can put some investment in. So as Paula talked about the mental health liaison service, there's now We Are With You workers attached to that particular service. And we've more recently added a We Are With You worker into our homelessness provision in the City of Lincoln. But I think there's more to do. And I think, you know, it's certainly something we're talking about in regards to our planning this year. How do we strengthen that offer so that we are ensuring that people don't fall through them gaps? But yeah, thanks for the question, Rob.
Okay, thank you. I've got Councillor Smith next, please.
Thank you, Chairman. I must say, from where we were in our working group, it hasn't been a very long time, but we seem to have come quite a long way in the right direction. I'm very pleased to see the end to what I call age barriers, which is where you hit a certain age and you just stopped. And transition, in my experience, through bereavement was non-existent. I went off a cliff edge, quite literally. So I hope that will put an end to that, because that is exceedingly traumatic for anybody when you're involved in that situation, and you have to then retell the same story and the same painful things. Again, you lose all confidence that you had built up previously. Secondly, Chairman, I think a full review is the right thing to do. I have a number of experiences with people I've tried to help professionally and personally, and unfortunately, if you don't fit into a nice little box at the moment, you fall through the cracks. A very good friend of mine is not considered high risk enough to fall into one category, fits in another, but has often, they then say, oh, we can't do anything for you because you're too severe, but you're not severe enough to go over there. So you get left in limbo and you fall through the cracks. And this I think we need to keep, shall I say, a watching brief as much as we can on this review, Chairman, and have as much information brought to us as possible to ensure that our residents get the services they need. With your indulgence, and it's very brief, Chairman, on the subject of dual diagnosis around alcohol, drug misuse and mental health, I'm very pleased to hear what's just been said, because in my experience assisting a number of people in that in a previous role, you had a merry-go-round of what came first, the drug or the alcohol. And actually, whilst there are certain things you can't treat mental health-wise whilst they are intoxicated, you can't do one or the other, because by the time they are in a position to deal with the mental health, it becomes too painful, so they fall back onto the drug or the alcohol that they were having an abusive relationship with. There needs to be a much more joined-up way of thinking whilst being clinically safe at the same time, Chairman. So it's very pleasing to hear that that's now starting, because that's sadly been long overdue, but it's very pleased that we're going in the right direction.
Yeah, if I could come back on a couple of points, I think particularly around those gaps in services, you're absolutely right. You know, we've still got work to do, but very much the desire to ensure that people don't fall off that cliff edge or don't fall between services. That roadmap that I talked about in terms of community mental health transformation makes an awful lot of reference to those elements of care. For example, the talking therapies department that we have, and then our community mental health teams, there has traditionally been a grey area that you've just described really articulately, that you know, not quite severe enough but too severe for. The introduction of our integrated place-based teams, I know that's a little bit of a mouthful, but those are teams that sit a little closer to primary care and in communities, very much tasked with that, and a lot of their work has been around identifying people that are falling through the gaps and ensuring that we've got that offer. So still work to do, but very much part of the ambition. And absolutely, in terms of the dual diagnosis element, we can no longer view the different issues in isolation. and we need to continue to do the work to pull those services together to meet people's needs. And thankfully, in a way, the kind of national sort of directives, the nice guidelines are saying very much the same thing, that you need to work together to address people's needs and not try and treat them in silo, which is ineffective, essentially.
Yeah, thank you. I'm just going to build on as well from what Councillor Smith was saying. On page 119, the report states that the average waiting time for talking therapies can be from 6 to 18 weeks, though performance is better in Lincolnshire. Can you advise if a patient enters the system via crisis and gets to a point where it is felt they can be released from this service to begin talking therapies and have to wait, best case, 6 weeks, what support is in place as an interim, as I'm aware of cases where this becomes a vicious circle of release, await, and then bouncing straight back into crisis, and then never actually making it through to the talking therapies?
Yeah, perhaps a question for me again there. I think it is challenging. It is, the talking therapist department is regarded as a service for people with low risk and mild to moderate difficulties. That's where the evidence suggests that the best outcome around therapy will happen. But you're absolutely right. People waiting or people prior to waiting will have mental health crisis and go through our crisis team. I guess what we would hope is that people reach a level of stability with the crisis team, that they're able to access the talking therapies. Assessments are generally much quicker than that 6 weeks, although can be 6 weeks. And admittedly, that is a difficult time for people while they're awaiting. And we do advise on how to access the services or other services or help on an urgent basis. We've talked about the mental health helpline. But yeah, I acknowledge the difficulty that can have for some people, and we do try and keep those waiting times in our talking therapist department as short as possible within the resources that we've got, but I fully acknowledge that difficulty and that challenge.
I think I'll just add to that, councillors, is that previously there's been a limited number of options for people. We've had our crisis services that probably been quite small. We've had inpatient wards, community mental health teams, an IAP service, and I think what you've heard today is we're working really hard to expand the range of options that are available to people. So even if somebody is waiting for a service, there should be a wraparound support through helplines, through community-based provision, through crisis cafes. And as we build those support structures around communities, hopefully there'll be a less reliance on crisis teams and other things. And we are starting to see a shift in demand. Probably too early to say that that's going to be sustained, but we're starting to see a shift in demand where people are feeling more supporting communities that frees up the capacity of our crisis teams. And so it is a space we know we need to do more in, hence the work we've talked about today.
Okay, thank you. Councillor Parkin?
Yeah, I'm really interested in what we were talking about way back at the beginning of the presentation in terms of the community support available for people with mental health issues. And I'm kind of interested in at what point we are signposting people to those. In old money, what we used to refer to as social prescribing, but we've not used those words today. Now, are we looking at those as we're first identifying people with mild to moderate needs, or are we using these as a step down from people who have received quite intensive therapy or even been in hospital, having hospital support? Because in fact, there's something about here that we kind of put the horse before the cart in some ways, is that are we using those community service to prevent people getting into crisis, or are they only the route out? Because in fact, surely there's got to be a balance somewhere where we're utilising those services as both.
Yes, thank you for the question. And absolutely, all of the above. They are not just intended for people to step down. I guess what's hard to articulate, or perhaps I didn't articulate well, that those elements to the pathway that we've described through primary care, secondary care, and the voluntary social enterprise sector is accessible to everybody. So you don't have to be just in one part of it's a continuum rather than a linear type approach. So absolutely, if you're engaged in intense therapy with our community mental health teams, you're absolutely can absolutely access those things in our communities. Nightlight cafes, you know, are staffed by volunteers. They're not mental health experts per se in how to manage crisis, but they give a place for people to access support as and when they require it. But they could also be under a crisis team at the same time. There's no, it isn't, it is, you know, we would like to think about it as step down as well, for people to be able to go and live their lives independently and as part of their communities, but they're also part of their communities while they're unwell. So there's no reason why they can't access at any point in their journey. I hope that answers the question.
You know, in a way that's reassuring, and thank you for that. But are we sure? I mean, the figures are huge, and are we sure we have enough resilience and capacity in all the areas of our county for that? Particularly when we're looking at people in the rural hinterland, where public transport is a massive, massive problem. And is there support that we can provide for people maybe to get into more of the urban centres, if that is what is needed to access that support?
Yeah, I'm happy to come on that one. Absolutely. What we're trying to do, and it's going to take a while to get there, is to build up the range of support that's available in all communities, and certainly in that philosophy we've got as an organisation and the national direction here in Lincolnshire as well, is to try to put as much support as we can into people's local communities. The idea of community supporting communities, and as Nick suggested earlier, or mentioned earlier, our crisis cafes that we're rolling out across the county. The nightlight cafes are now in 26 different locations. The idea is one in, you know, every town, ideally every village, if we can get the volunteers to be able to run them, and they link directly back into our crisis services. So recognise we can't put everything in every village. There has to be some sort of some centralisation of services, but as dispersed as possible. And then again, it's about what we can take out. You know, Paula mentioned earlier about the crisis response vehicles. We can get out to people's communities as much as possible, but there's always going to be an element of travel for some elements of service, particularly those more specialist services that we provide.
Thank you. Councillor Morgan.
Thank you. I looked at the coroner's report for last year, and it's really quite shocking that actually, if you come, looking at suicide alone, the rates in our county are actually increasing. And if we look at drug and alcohol as well, they are also increasing causes of death. And if you look at each of those individually and certainly combined, they're actually the largest causes of death in our county. So it kind of puts our focus on how important what we're doing and what's been done is. I'd like to touch on a few areas, if I may, around Grantham. I'm very concerned. We talked about equality of service. But I suspect that the loss of some of the A&E facilities at Grantham, which I know this committee has previously raised concerns about, are actually impacting on the ability to access emergency health care as well. I don't think it's acceptable to have the difference in response times of 3 hours between Lincoln and Boston and the residents of Grantham. That is really concerning. And if we say, well, the fallback at night time would be for the residents of Grantham who need help and support to go to Lincoln, as has quite rightly been made the point earlier, transport is absolutely atrocious. I will phrase it, is non-existent. Public transport at night is non-existent between Grantham and Lincoln. So how do we support those patients or people who are in mental health crisis get to our new amenities that we are providing elsewhere? With regards to the nightlight cafe, we've actually got one in Grantham. And my general understanding, I happen to know a number of volunteers working there. They generally do a really, really good job. But maybe this highlights the issue that recently we've had fatalities linked to people going to the nightlight cafe who didn't have access to the other more professional help that they may have needed. It is really concerning. I would like some feedback on this, please. I'd like to see what we're going to do to improve the urgent care at Grantham specifically, and what transport support we could potentially provide those people in an emergency. Thank you.
Before you
Thank you,
respond,
Councillor.
I just would
I'm
say
sorry.
we're sort of touching somewhat on this afternoon's item. So I understand where you're coming from with the mental health element of it, but of course the closure of Grantham, you know, as an A&E is later on in the session, realistically. So though I completely understand where you're coming from, I would also say that we looked at suicide. We actually had a working group. That's how all of this has came forward, to be fair, because we are aware that there is that issue there. So there's that element as well that it stemmed from there. But I'm more than happy for a response there. But as I say, anything when it comes to the actual closure of A&E, I think the same could be argued for probably most areas in Lincolnshire, especially on the East Coast, where we're already having to, you know, spend hours travelling as well. So totally support where you're coming from in essence. Thank you.
Yeah, thank you, Councillor. Thank you for the question. And as I say, I won't stray into response times at an A&E as such. From a suicide prevention perspective, absolutely key agenda for us in mental health services, as you would imagine, and so certainly for our colleagues in public health. There is a suicide prevention group that's a multi-stakeholder group across the system that's led by public health that we're absolutely a part of, looking at different things we can do to try to really help people to sort of get the access to help when they need it, and to reduce the number of people that might take their own lives. And obviously people who take their own lives are not necessarily involved in mental health services. There's a whole range of issues there that come into play, but that's why we need that multi-agency response, which we're absolutely part of. In terms of, well, I'll ask Paula to come in just a bit around what crisis support, for mental health crisis support we provide in Grantham, and what we're doing around that now and in the next kind of 12 months.
Thank you. Thank you. Yeah, so absolutely acknowledge where some of the challenges are in terms of the provision that's available in Grantham. One of the things we have been doing is working very closely with Nick, and also with our nightlife cafes as well. So that offering has been extended geographically. So we've got a number of nightlife cafes across the county. So linking in very much with those services. But again, acknowledge that the provision in Grantham is different to what's available in other parts of the county, and like you say, we have got a difference in response time. So you know, as has been outlined, you know, there is a difference in terms of 3 hours between the 1 hour response times for Lincoln and Boston and the ones in Grantham as well. We will always try to make sure that we are offering support to the people of Grantham should they be in a mental health crisis. Like I say, we'll be looking at support through the mental health helpline. We'll be looking at support with our voluntary sector colleagues, and we'll also link into other services within Lincoln and Boston and the Louth area as well, to make sure that we've got a robust offer across the whole of the county. So if there is an increase in demand in one area, we will look to move resources to make sure that we are responding appropriately to people within a mental health crisis, but absolutely acknowledge that at the moment the response times are different.
Okay, thank you. I've got Councillor Allen.
Thank you, Chairman. Well, the people of Sleaford always had to move to a different place. They never had a great deal of provision locally. And it may take more time to get to Sleaford than elsewhere as well. But this is a Lincolnshire County Council committee, and we do look about providing the best provision for the county as a whole, bearing in mind its demographics and its different densities of population. I would like to thank Nick, Chris and Paula for the presentation. I thought it was very detailed, and it did provide a very good, I think, overview of the where the review is. So it was a good update in that respect. And like every other service provision within the National Health Service, I'm sure there's challenges, and some of those have been alluded to with the questions that have been raised by my colleagues today. So I'm not going to go through those again. I've got two areas, I think, which I have some concerns about, and it's to do with accepting that resources are very, very important to provide the service that's required and to deliver, response times and deal with issues as they occur and arise across the county. So the two questions I've got is there anything that can be done locally, or is there any initiatives taking place that provide more resources or training for people to become service providers, both locally and nationally. So, you know, is the resource, are the resources missing? And is there something being done to actually address that? And I know there was a comment made about international recruitment, and I don't want to go on about international recruitment at all and the morality of doing so. I think it's always far better to provide our homegrown resources and try and maintain them, so that we don't provide resources that go off to Australia and New Zealand and the United States, whilst we recruit from India and other places, which seems to be a most peculiar situation to get ourselves into. And the second question is, it's again to do with, are we adequately resourced? There has been some suggestion that the police pull out of any form of mental health support, so they won't go into deal with some of the early situations and events. And it does strike me that if that is the case, and I don't know if Lincolnshire is following some of the bigger forces, but I can understand why they might do so. And I did wonder then whether the mental health service is looking at that and thinking about what might be required to deal with it if the police aren't going to be there to effectively be first port of call for some of the issues that are associated with mental health. That's my questions. 2 questions there.
Thank you, Rob. Oh, sorry, Chris.
No, thank you. If I just start, and I'll probably bring you in for that piece around the system training in a second. Just to pick up a couple of bits there, just in terms of wider training, we work quite proactively, obviously, with our recruitment challenges. We're looking at to know every stone and opportunity that there is to attract and retain people into the organisation. So we do a lot of work with our local universities who are a pipeline for registered nurses and other professionals. We've got our own apprenticeship scheme that operates within the organisation, that we can grow our own staff, and we're again really looking at those different options, including international recruitment. So really looking at different ways to bring people in. We're also looking at alternative roles that we can develop ourselves, so train our own staff, grow our own in that respect, to supplement our other professionals that we've already got in our workforce. So we're trying all the different angles around that and making sure that we've got the right number of people coming through those formal training programs to do that. The other bit just to say around the police work was your second question. Yeah, there's some national changes under the Right Care Right Person an agenda. We're working really closely with our police colleagues here in Lincolnshire. We've got a really positive relationship, as we have with most partners in Lincolnshire. I think we're really fortunate in that respect. And the police are working with a multi-agency group that we're a core part of to look at how that might work for Lincolnshire. And what we've heard through that work is that we'll make sure that programme works for the people of Lincolnshire whilst trying to adhere to the national requirements of the programme. So at this stage, we're confident that the relationships we've got will make sure that patients, people don't suffer negatively from whatever changes might or might not come. But I'm confident in the relationships will get to the right place in whatever that work looks like. So so that's probably as much I can say on the police matter. I just want to bring Nick in just to talk about some of the wider training we're doing for systems and partners that's underway at the moment.
Yeah, thanks, Chris. So yeah, as part of the community mental health transformation programme, this is obviously an area that we've debated and discussed quite frequently, because we're asking people to work in a space that they haven't worked in necessarily before. So yeah, really important that we upskill people in the basics, I guess, in terms of mental health awareness and how to respond to people in crisis. So quite recently, we've put together a training package for all our system partners. It's mostly access to online training and other elements of awareness. And we've produced some kind of leaflets and cards with all that information on, which I'll be happy to send over to anybody that's interested. And we're encouraging all of our partners really to participate in that. And we've also got the mental health first aid training. There's quite a number of people in the county trained in that, and that's something that public health will be picking up and ensuring that training is kind of wider. And there's ongoing support and supervision around that, because it's sometimes having training is fine, but then where do you get the ongoing kind of support and skills development off the back of that? So yeah, very much in our thinking. I'd like us to do much more kind of live training and a wider suite of programs, but we've made a good start, I think. So yeah, hopefully that's going to be useful for people.
Okay, thank you. I've got Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. We talk about Lincolnshire, but unfortunately, if an ambulance comes to a place like Louth and picks somebody up, they invariably take them to Grimsby. And I had an experience recently with a homeless chap who had complex needs, and he was, when I managed to get down to where he was bringing up blood and he was shivering and all the rest of it, so he obviously needed to get into a hospital, and they could, until his condition was stabilised, they couldn't actually treat his mental health condition. But then, because he'd gone to Grimsby, his family told me that the mental health provision in Grimsby is entirely different, and the mental health provision there wasn't talking to the mental health provision back in Lincolnshire. And I wondered how you dealt with that, really, how we got to the bottom of it to improve that for our residents. I also wanted to actually say something about the community connectors. I was chatting to one on Tuesday in Louth. She's just had her area expanded yet again, a huge rural area. And she was telling me she gets quite frustrated because she spends most of her time with people who are coming in and asking her for help with gas and electricity because they can't pay their bills. And that was actually stopping her from doing her job. So I just wondered how we could cope with that. And I just wanted to give a shout out as well to the Lincolnshire Rural Support Network, because they do an awful lot with farmers and people with mental health problems. And I don't think we pay them enough tribute for what they're doing. And they do an awful lot with suicides with farmers, because it's not uncommon in farmers. So I would like to know how we actually work through these things that we see practically on the ground, which perhaps the professionals don't necessarily see in quite the same way. Thank you.
Thank you for the questions. I'll pick up the first one first. The ambulance conveyances, and I'm sure people are familiar with the ambulance's own pressures and how they're operating, and obviously they'll take to the most convenient and suitable place for somebody. But I can't really comment on their operating model. What I would say is that we, through our own teams, we make sure that we've got links in with other hospitals and other providers around the county, around the country. People from Lincolnshire could end up in I suppose with anywhere in terms of where they might be on holiday and when they come unwell, and we always try to make those links and be accessible. But obviously that's a two-way process, and we are obviously reliant on understanding and knowing that somebody is in a different area. But certainly I'd hope that our services are responsive to that, and that we arrange, I suppose, the most suitable thing for them to either remain there if that's right for them, or to return to Lincolnshire into our own service if that's a better option. So if there are details about that particular case you want to share outside the meeting, then more than happy to look into that one. Nice shout out about the Rural Support Network. Absolutely key partner for us. We recognise the work that we're doing, and we're really focused on supporting them to continue and build upon the offer that they've got. But absolutely recognise them as a key partner in our wider care network. But I'll pass over to Nick just about the community connector role. It's something that sits in his area of responsibility. So if you could pick that up, Nick.
Yeah, thanks, Chris. That was really interesting to hear. That's not something that's come to my attention, although I guess not unexpected in terms of some of the social determinants of mental health related to finance, debt, and those kind of the difficult financial circumstances and cost of living crisis that we find ourselves in. But yeah, I guess I would need to understand a little bit more about what's available in that area for signposting too. Got strong relationships with the CAB in a number of our towns. I'd need to kind of check out that provision in Louth, and if there's something we need to do about that to strengthen those relationships. We do have gaps in some area around that provision, but yeah, I'd be interested to have a look at that outside of this, just to understand that, because yeah, that's not entirely her role and responsibility. But if that's being inundated by those kind of requests, we need to ensure there's the alternatives and the signposting to appropriate services for that.
And also, could we have some of your leaflets, please?
Absolutely.
Thank you.
Thank you. And we will pick up with the ICB just on some of the areas you covered there, Councillor Mackinson-Saunders, to try and get a bit more of a response on how they see that relationship across the sort of boundaries and borders that we've got there. Okay.
Well, there are a lot of problems going across boundaries.
Yeah.
Thank you.
And we'll pick that up, so that's not a problem. I've got the Vice Chairman, Councillor Linda Wotton.
Thank you, Chairman. And Chairman, I think you will agree with me. We've had some super, really informative papers today. And this one that we've been presented with is excellent. It gives us so much information, and our three presenters have given us a great presentation and answered lots of questions. But I've just got a couple myself. My colleague over there, Councillor Kendrick, brought up about volunteers, and if he's got some fears about the capabilities of volunteers, I'd like us all to share into any information there. And that leads me on to the fact that we've got 4 SK councillors here in this room. 3 of us actually live in Grantham, and this one in particular, I don't know where the Nightlight Cafe is, and also the Grantham Hub. So if you could answer those 2 questions for me, I'd be very grateful. And I've just got a comment. To have the Urgent Assessment Centre for the A&E in Lincoln, I think is absolutely brilliant. And to see the investment in the Peter Hodgson Centre, I really think that's bringing Lincoln into the 21st century. And I thank you for all the work that you do. Thank you, Chairman.
Well, thank you for that. I think it was more of an observation around volunteers, and certainly we really embracing volunteers in our workforce, and we offer training and support for any volunteers that work with us, and obviously in that extended network through the community volunteer services sector, the suite of training programs that Nick just mentioned in the previous question are available to those groups, so that we can make sure they've got opportunities in place. And I share your pleasure on the investments we've made in some of our environments. It's really good to see. But I don't know if you just want to make any comment on the Nightlight Cafe and locations, Nick, or certainly maybe send some information out afterwards if not.
Yeah, and if I may, just a brief word on the volunteers too. In terms of how we've organised the provision across the county, we've got quite a robust process of selecting organisations that want to bid for money, and that's a joint kind of a partnership between ourselves, the ICB, and the local authority. And we have an organisation called Shine that supports the system in terms of supporting voluntary and third sector organisations to be capable. So there's an ongoing package of support for that sector, and they're heavily involved in that. And where organisations don't feel quite ready and aren't quite sustainable or couldn't host the staff, Shine will do that. So I feel we've got quite a robust process in place for, and you know, they provide an awful lot of training and development opportunities. And in terms of the hub in Grantham, it's at the Ascension Church Hall.
And Councillor Wootton said, and the cafe, is that in the same location?
I would need to check, but I believe so. I think they operate out of the same space.
Yeah, Councillor Morgan.
Yes, may I give a point of information? It's actually located in Beehive on Finkin Street, which is run by the Selfless Links Blind Society. That's where the night light is.
Thank you. I'd just comment further that I've seen, you know, advertised particularly well in Skegness, so I would hope it's sort of following the same, you know, route and social media. It's advertised every week. I think it's a Friday night every week in Skeg at a certain time, and so I was quite impressed at how well it was being shared out there, and it'd be nice to see that it's following a same sort of advertising link out there. And I think BroPros helped considerably with the Nightlight Cafe and the advertising there as well. So yeah, they're excellent facilities, and you know, I think they should be commended, most certainly. So I've just got, I think, 2 questions left myself, and then I think we'll close down the debate and thank our speakers. So is there any news on the proposals for mental health advice from NHS 111 as part of the integrated care approach yet?
Yes, so we're currently working with the national team on that proposal, and we've got a team of people here in Lincolnshire working up how that might operationalise for us in the county. There's some indicative dates for kind of the back end of this this financial year, sorry, for that coming online. We're just working through that with regional and national colleagues. But ultimately, the intention is that people will be able to dial 111, press option 2 for mental health, and that will be navigated through to our own services in the trust, so that we can appropriately support people and get them to the right place. So that is a piece of work that's underway. It's complicated, as you would imagine, in terms of not just the technological solutions, but making sure we've got the right response times and services in place. But there is a piece of work underway to make sure that's in place by the end of the financial year.
Thank you. And this one, I think I probably know the answer to, but I'll ask anyway. Do you see demand for mental health services stabilising or increasing over the next few years?
Well, that's an interesting question. Just in the fact that some services we've seen having a significant peak in demand during and certainly after COVID and the pandemic. But for some services, that appears to be tailing off now and levelling out a little bit. That's still hit and miss in areas, and we've still got a backlog of people, that volume of people that came through to deal with. But then more broadly, and I suppose that's for some of our specialist services. More broadly, we are seeing demand rising across the whole of the mental health population, I suppose, from a mental health perspective. But what we're trying to do is make sure we've got more of these services in place earlier on. We can see that we've got rising access rates across everywhere. We've got more people accessing services than ever before, but some of that's intentional. We've expanded services and expanded the offer at that, so that early intervention and preventative agenda, so that we can support people earlier on and hopefully prevent them needing more specialist services down the line. So we are seeing access increase. Some of that's intentional. It's really hard to say, but we know that mental health is affected by such a wide range of factors, and we're all none of us are immune to those life events and factors that come along, and we're seeing an increase in those different things, the pandemic and all those different things that have really impacted on people's lives. So if I was to say, is it rising? More people are accessing services, yes. Will that continue? Probably.
Okay, thank you. I'm going to go to the proposal, in which case, and that is that we thank the Lincolnshire Partnership NHS Foundation Trust for the presentation on adult mental health services. I think it's been incredibly worthwhile, and the committee would all fully agree that we appreciate the level of detail within the paper and presentation, so thank you. And secondly, that the committee be advised of any future development in these services moving forwards. Do I have a seconder to that proposal, please? Thank you, Councillor Smith. All those in favour, please show. Thank you. That's supported. And that brings the afternoon session to a close. And just once again, thank you to our presenters. And I'll see those of you that are coming back for the lunch after lunch at 2 p.m. for the next session. Thank you.
Thank you.
Thank you.
Good afternoon, and thank you all for attending the afternoon session. I've been asked to request that anyone who speaks, if they can bring the microphone closer to the mouth, because those that are listening in on YouTube are not able to hear you unless it's directly in front of your mouth. So if you could ensure you do that, that'd be much appreciated. We'll now move into agenda item 9, the Acute Services Review, Grantham. This item is found on pages 131 to 135 of the agenda pack. This report is an update on the implementation phase as decisions on the urgent treatment centre at Grantham and the acute community beds were made in May 2022. I'd like to welcome our presenter on Teams, Pete Burnett, Director of Strategic Planning, Integration and Partnership for the NHS Lincolnshire Integrated Board. I'll hand over to you, Pete, just to run through for 5-10 minutes maximum, and then we'll take questions at the end if that's okay. Thank you.
No, thanks, Chair. Much appreciated. So, yeah, no, thanks for inviting me into committee today. I'm going to give an update on where we are with the ASR programme and its implementation, specifically focused on urgent and emergency care and the acute medicine at Grantham Hospital. Just to confirm, the ASR programme included 4 core service changes for those who haven't got the background on this. One was around orthopaedics, and that's consolidated planned orthopaedic surgery at Grantham District Hospital to establish a centre of excellence there, and also to establish a dedicated day case centre at County Louth. In terms of urgent and emergency care, the ASR programme looked to change Grantham District Hospital's A&E department to become a 24/7 urgent treatment centre. Around acute medicine, it was to develop an integrated community acute medical beds at Grantham District Hospital, and that replaced some of the acute medical beds on site in place with it, should I say. And the stroke services to consolidate hyperacute and acute stroke service at Lincoln County Hospital site with a dedicated enhanced community stroke rehabilitation service alongside it. So that was the ASR programme. They were the recommendations. They were taken to the CCG board, because the CCG were the kind of decision-making authority at the time, back in May 2022, and they approved the changes for all 4 services at that stage. We then came back to Health Scrutiny in June to discuss the decision, that the evidence that we had through the kind of consultation process, the evidence we had in the response to that consultation process, and how we'd come to making our decision following the review of all the feedback we'd received. So we did that in June last year. We then were requested to come back in November, I think, or December time, to present on where we were with the implementation of each of the 4 services which we provided. And at that time, the request was then to come back again on the urgent and emergency care change and also the acute medicine change, which is why we're here today. And actually the feedback at that time was to ask us to focus on trying to ensure we had local providers delivering the services if possible. So that's where we got to, and that's how we've gone through the approval process to that date. So I thought I'd take you through kind of where we are with both those services and how we're kind of going for the kind of in terms of implementing them going forward. So during the autumn of last year, we had joint working groups across the NHS in Lincolnshire that we worked together on developing the kind of integrated spec for both services, for both for the new UTC and also the integrated community acute medical beds. That working group was made up of people across the ICB, ULHT and LCHS and general practice, and it included people who currently work within the services, both the kind of ward-based beds and also the current A&E service, so the matrons and people within, as well as senior clinicians across the piece. And their aim was to develop the service spec both in line with, in terms of a UTC, what the national spec is, but also what we had in our pre-consultation business case and what we said the service model would look like, and also in line with the kind of feedback we've received from the public. They developed the service spec. A good piece on this, for example, in terms of the urgent treatment centre, through that work and the development that happened and the feedback we received, although it's always going to be in a 24-hour open access service, actually the proposal in the pre-consultation business case was for the medical mid-grade doctors to stop being on site from 10 o'clock and come back on site at 6 in the morning. And actually the group thought it would be better to have 24/7 cover cover for medical, for mid-grade doctors to be on site. And that's the kind of change they worked through and said, okay, we'll put that into the service spec work. That work was done to inform the final service specification, but the ICB then had to approve that. So we had a exec working group that included myself, Director of Service Delivery and Performance, Medical Director and Director of Nursing to work through the specs. We had 3 meetings to go through each of the service specs to make sure actually they're in line with both what the national requirements are, what our pre-consultation business case requirements are, and what the feedback we'd had and we said we'd commit to in the CCG decision back in May 2022. That review was undertaken, and then the specs went to the ICB exec team for approval, which was then granted. Once we then had the service specs, we knew what the service model was going to look like. We could turn our attentions to the procurement element of this. And there's legal considerations about open procurement, the nature of change to the service. And actually, after quite some detailed discussion, we came to the conclusion that the patients and the public of Lincolnshire, and certainly the Grantham surrounding areas, would be best served by maintaining our current service providers in terms of delivering those services. In terms of the UTC, because it has enhanced levels of care and has mid-grade doctors in and working in the department, we believed and made the decision that actually the UTC would better be led wholly by ULHT. So they're going to be awarded that kind of contract for running those services. And in terms of the integrated acute community medical beds, a joint approach between LCHS and ULHT was required as part of that model. So that was the decision that was agreed across all partners. They're the best way to go forward. And that now led us into the implementation stage of where we are. So we're currently, both organisations are working on the acute medicine beds and working up the granular level detail around how that's going to operate and the plan for making it go live. And ULHT, in conjunction with primary care and LCHS, are working on the UTC and the requirements, because there's obviously recruitment requirements and policies and procedures that need to be put in place for that to go live, and that work's now underway currently. The aim, the plan will be both services will open in the autumn of this year, ahead of the winter pressure period. We haven't got a confirmed date yet, but I was hoping we'd have one by today. We haven't got it just yet, but hopefully we can let the committee know what that will be in due course once agreed. But that's where we are. So we're now into mobilisation stage. The trusts are working on their mobilisation plans, and hopefully we'll have the service. Well, the service will be in place in the autumn, as in line with the to deliver as in line with the kind of consultation exercise we ran. Thank you.
Thanks, Pete. I've got Councillor Ray Wotton first, please.
Thank you very much, Steve, Mr. Chairman. The main thing for this, Mr. Chairman, is that the public of Grantham and District and surrounding areas should actually come first. As you know, the hospital has been temporarily closed overnight since August 2016, and despite rallies, petitions to Downing Street, campaign groups, cross-party working until recently, the public, I think, have been let down. The public in Grantham and surrounding areas want the hospital open 24/7 in Grantham, a proper A&E, not a UTC. Although I do welcome some decision that's going to be made, but I want to know, we were promised that UTC was going to be a UTC plus. What happened to the UTC plus? And how many beds are there going to be? I mean, at the moment, I've suffered a heart attack and also a stroke, and I've had to go to Lincoln on a couple of occasions, and I waited 13 hours for a stroke service in A&E Lincoln. Really disappointing. So I want to know is what services are going to be provided at Grantham and when? Thank you very much, Mr. Chairman.
Yeah, so just respond to those points. So previous discussions we've had on it being at A&E, the fact that you go to stroke and for stroke to Lincoln for stroke and if you had a heart attack is a demonstration of the service provision at Lincoln County, at Grantham Hospital compared to Lincoln County. We are aiming to, we will open a 24/7 open access service at Grantham Hospital in the autumn, in line with our kind of service model as described to the committee back in June. Largely every patient, if you look at the patients who are going to Grantham A&E prior to the overnight closure in 2016, all but 3% of those patients will still be treated at Grantham Hospital by that UTC. There's also the ability to book in patients into the UTC, people to book an appointment at the UTC, as well as open access throughout the day and night. At that point, and that so it's both ability to do both, shall I say, in terms of making that happen. So that's the service going to go in the integrated community bed. So there's 3 wards within the hospital around medicine. Returning one of those wards to have an integrated approach. So we'll have therapists working on the ward, and that will allow patients to be stepped up into that ward from the community without going through the UTC, and also the ability to step out into the community because it's done in a joint model. The community teams that work in the community will have a better understanding of the care they've had, and that kind of integration between both models will hopefully benefit the patients of Grantham. And the aim, if you look at the clinical Senate review into that model of care, that was really highlighted as a strong model, and the aim will be that actually we get this right here, we'll then roll that out at other areas across the county, because it will link that kind of the both acute and the community bit together, which would be good. In terms of the plus, I think we have gone over this quite a number of times. The intention was to call it a plus, but when the clinical Senate reviewed our proposals as part of the pre-consultation business case development, we were informed that we can't call it a plus, so we have to maintain it as an urgent treatment centre, and that's the decision that's been taken, and that's what will be put in place this autumn.
Thank you, Chairman. If you just understand that the feeling in Grantham and surrounding areas is that the people do want an A&E open, and that the campaign, know you made your decision and you can't change that decision, but that's not what the people want, and we want to see the best service for people in Grantham. Excuse me. Sorry, Sharon, I got to stop. We want to see the best service for people in Grantham and surrounding districts. Sorry, Chairman. Thank you.
Thank you, Ray. Pete, I don't know if you would want to come back any further on that.
Well, no, because I think we're just going to open up the decision to be made. The consultation process we went through last year came back. Actually, if you look at it, 50% of the population, there was support for all the proposals. I can't remember all the top of my head, there's support for all the proposals. This is the right model of care. If you look at it, there's 2 patients a day that will be being transferred that would have been looked after pre-2016 at Grantham Hospital moving out. The patients, this service brings back in, you're right, it's taken too long to get there, but it brings back in a 24/7 open access service that meets the needs of the local population. And I won't go over the A&E discussion. This is not a too dissimilar service than was in before, but will be quite correctly titled an urgent treatment centre.
Thank you. I think just before I bring you in, Councillor Wotton, I would say I think we've got to be careful we don't go over old ground. The decision has been made, it's been signed off by NHS England and everything else, but absolutely it is the role of this committee to ensure that we get the very best service possible for the residents of Grantham moving forwards, and we need to ensure that we keep this on the radar and we ensure that implementation is the very best it can be.
Exactly,
right.
I fully agree with that, Chairman, yes. Just that the service in Lincoln, although they've got an A&E there, is overcrowded and people are waiting too long. I mean, one of our colleagues from County Council waited nearly 30 hours to get treatment in Lincoln, which I think is wrong. Thank you, Chairman.
It's all right, Pete. I can't see you on the camera straight away, so I don't know if you put your hand up or anything, but yeah. I don't know if you want to respond to that. It's not, I think, individual cases.
I can't respond to A, to the individual case, but B, it's not my role to run the ED at Lincoln County, so it's probably right to speak to ULHT or our urgent care colleagues. I think they're planned to come back in October to give an update on the urgent care pathway. Includes the EDs, so it's probably the best place to pick it up then.
Okay, thank you. We'll ensure that's noted down. Councillor Morgan, please.
Thank you. Well, first of all, I'd like to thank Councillor Wotton for his comments, because actually, although a decision has been made, I think one keyword I'd like to change, Councillor Wooden said people want to have a 24/7 A&E. I'll rephrase that, people need a 24/7 A&E because the distance Grantham is from all other A&Es in the area. It's central. Unfortunately, there is no near A&E alternative, and some people are travelling 40 miles to get extra care elsewhere. What I'd like to pick up on, first of all, I'd like to come back to the consultation response. And I must declare, so I didn't at the beginning of the meeting, I am chair of SOS Grantham Hospital. We were heavily involved in the consultation process. We had responses back from over 1,000 people, which we submitted. And I will tell you now, where the 50% came from, I do not know, because over 95% of our respondees disagreed with the proposals. They were seriously concerned. And one of the problems we had was the lack of detail about what services would be provided instead. And I'm going to say, looking at what we're being presented today, that issue's still there. It's all very waffly, it's all very high level. Where is the detail? We had a very clear list of what services were available at Grantham Hospital. I will dispute quite clearly, based on that evidence from Freedom of Information request, that they couldn't deal with stroke. It could actually stabilise strokes. It could deal with most heart conditions as well. We need to know what we've lost, what we're getting very clearly, so members of the public know where to go for help, because at the moment it is really, really grey. If anyone thinks there's no need for that unit, I had to go there with my daughter only the other day. People were queuing outside the door to get into Grantham A&E at 6:30. There is a definite need for that unit to retain. It had consultants. The other point goes back to the plans and talking about the mid-level service we'll get. The acute care beds before were actually supported by consultants, not therapists, by consultants who could deal with heart, stomach and respiratory conditions for complex cases for our elderly. And it's still not clear what level of service we will get that matches that, because the alternative is our most vulnerable, most elderly people who used to go into Grantham and recover and go back into the community, where will they get that treatment, and will their families and everyone else be able to support them in hospital? I'd like to thank the committee, because I know you did support Grantham at that time and did oppose these plans, but I still feel there's a huge issue around the lack of detail. And here we are only months before we're about to get service. This report is, to be frank, too thin. There's just no real information for us to go on, for us as a committee to identify the true impact on our communities of the changes. Thank you.
Okay, I'll try and respond. There's quite a lot of questions in there. So the consultation feedback, the full level of the spec work, the full level of the detail around each service we came to back in June last year, and went through all the kind of feedback, how we responded to that feedback, how we continue to respond to the feedback based by the fact it's 24/7 mid-grade cover in the UTC back in June. So I haven't come here today to re-go over that, because the committee's already heard around the whole response and how we listened. So we met Councillor Morgan during that process, and you can see in the documentation that we presented at the committee last June where your responses are and how we responded to that and how it's being taken forward in a joint pathway in terms of that. In terms of you were talking around what's the need of the population, that's what we, following the review, following the clinical senate, following all the clinicians across the county that have worked on this programme, this is what they believe is the best model of care and right for the local population of Grantham and the surrounding areas. that is part of a network of hospitals. With both, because if you might have major trauma, you might get stabilised at Lincoln County. You get taken to Nottingham University Hospital because they're the major trauma sites. Same as you come to Grantham, you might get stabilised for strokes. You had a stroke, you get taken to Lincoln County because they have the right service there to provide it for you. You mentioned around consultants in the hospital. So the level of medical cover in the hospital hasn't changed. What we're having is an integrated acute community ward, which isn't in place at the moment, that allows patients to be stepped down. So you have patients who might go into a hospital or go into, it might be Lincoln or Grantham. Actually, their step down care is done on the East Coast. This will provide an opportunity for a joint model for actually those patients that are elderly in Grantham can remain in Grantham. Also, they can be stepped up into those beds at Grantham Hospital rather than being stepped up elsewhere without going through the UTC to get that kind of level of care. But there are still consultants on site, so the medical cover hasn't changed. Consultants will still have oversight of those beds. Even the new ward will have consultant input into that work, and the UTC is pretty much as described in line with what was the A&E model before, but because it isn't A&E, it doesn't have the level of consultant cover that all destination A&Es have, but it didn't provide the A&E service that a type 1 A&E has. But I don't want to go over that old ground. This report, the reason it is an update on where we were in terms of the implementation. It wasn't a request for a detailed implementation plan. We can bring that back, but that's the reason why it says this is where we are at this stage, and that's the current position.
As long as it's brief, because I think you asked a large number of questions there. So.
Yeah, thank you. Well, first of all, I would just like to respond to the comment you made. You gave an example, actually, where somebody who could go to Lincoln and then be referred to Nottingham, but they've come from Grantham, so we could have a ridiculous situation where somebody from Grantham goes to Lincoln and then gets back sent to Nottingham. That's actually occurring already. The overall distances they've travelled, I'll let people work out themselves. With regards to the detail, though, going back to the findings of the consultation, it was actually highlighted that the most
Councillor Morgan, I think we're going on to consultation. This has been done. This is an implementation plan.
That's what
we can't go back over old ground. The acute services review is now completed.
Sorry, my question is regarding the implementation. I'm touching on it because it's very valid, you'll see. During the the consultation responses and the subsequent independent report analysing that, it was identified the most affected people by the changes would be the most vulnerable, who fall into the protected groups. So my question is, what measures in particular are going to be put in place to support those people moving forward? Thank you.
No, thanks. So just quickly on the pathway bit, that's the nature of networks of hospitals. So if you have a stroke, you might get taken to you would get taken to Lincoln County, but if they assess you and you need a mechanical thrombectomy, which is a very specialist service, you would then get taken to Nottingham University Hospitals. That is a true pathway. You can't identify if they need a mechanical thrombectomy until you get taken to Lincoln County and they do these scans. I think that's the right model of care. If you had major trauma, you more than likely would get taken by ambulance or air ambulance direct to Nottingham University Hospitals. But that happens if you're on the East Coast as well. It'd probably be an air ambulance. But they're the model. That's how care pathways work. You have specialist centres, really specialist centres, and then you have kind of general kind of centres, and sometimes it's about having the right care at the right time, and that's why it goes through, and that's why you have that model of care. In terms of the question around protected characteristics, that wasn't. It'd be helpful for you to identify that within the consultation report, so that would be impacted on those with most need. Actually, the impact of the service changes is across the area, and we have worked with those with most need as part of this. So we had consultations with different kind of community groups, but I'm not entirely sure what you were drawing on from the consultation report last time. Should say though, once we get the detailed timelines, there will be a clear communication plan that will go out, and that's part and parcel of the implementation bit, but we need to get the timelines in place. But an equality impact assessment process was completed, and there are live documents that we continue to review, and will continue to review during the implementation, because you are right, we do need to make sure when the change makes that we don't adversely impact on groups, and we'll continue to monitor that through this stage.
Very shortly, Councillor Morgan, and just purely on the point raised by Pete, please. Thank you.
Thank you. Yeah, the key areas identified actually were the elderly, disabled, children and those on low income. It was identified in the report they would be the most affected, and a lot of the issues are around transport, out of hours. How will those people, especially if they haven't got a car, get to the nearest A&E? Because to date, we haven't seen a transport strategy come to cover that from ULHT.
Yeah, so actually, by opening up 24/7 as a UTC, they'll have greater access locally than they currently have since the closure, and the access won't be dissimilar to what the access was prior to 2016, because Grantham A&E has never had, it's never been a fully, hasn't of all the kind of complaints. So you have a severe stroke, heart attack, you do get taken to Lincoln County, or you get taken to Boston Hospital in that regard. So actually open it back up will provide more greater local access at Grantham Hospital across the 24-hour period. The integrated acute community wards also allow people to be kind of come back in. If they've gone to Lincoln County, for example, because that was the right pathway of care, they can come back to that ward at Grantham Hospital, and therefore that would reduce some of the kind of families and carers travelling across the county. So that will help address that bit, but it is something we'll continue to review and monitor, quite rightly, once the implementation happens.
Thank you. Councillor Linda Wotton.
Thank you, Chairman, and I must support Councillor Morgan on this, to be quite honest, because within the equality impact assessment, it does say what she's just stated. I won't go over it again, but it impacts on the economicality and disadvantaged elderly, etc., etc. But that isn't my question, Pete, and thank you for your presentation. We have a unique A&E. It doesn't say what it says on, it doesn't do what it says on the tin, does it? So when we go over to a UTC, how is that going to be different to our A&E? Is it going to be a very similar service? Are there going to be any mid-grade doctors on the site? And will we see a difference? Because I actually live on the road where the hospital is. I've seen accidents quite near my house, and I've seen the ambulance crew take people off to Lincoln. And I do agree they've got to go to the right place to get the right treatment. But if you could answer those questions for me, please. And also, when and where will you give us a date for the opening of the UTC? Thank you, Chairman. Thank you.
No, thank you, Councillor Wilson. So there's not, from the service, the A&E, as you said, and the name of the A&E, as the Independent Reconfiguration Panel and the Clinical Senate from the East Midlands identified, hasn't been a true A&E since certainly by 2008 when the service changed, and there was a kind of a group of really ill kind of conditions that you get taken to Lincoln County or other Boston, Pilgrim Boston, for that. So it hasn't been, and those reports, for a matter of public record, identify that actually it hasn't been an A&E for some time, and that's been highlighted in that sense. The key problem we have is, one, as it's designated an A&E, A&Es come with a national requirement, a national specification for a level of consultant care, a level of mid-grade care that isn't reflective of the service offered within Grantham, and well, that was in Grantham Hospital, and therefore you're putting in a level of care that doesn't meet the need or is over spec for what was coming through, and the trust struggled to actually recruit those level of grades, because those grades want to work in the more kind of true A&Es where they see the full set of kind of conditions coming through. So the actual change that you will have is, yes, there will be 24/7 mid-grades. That's one of the changes we had, because when we consulted, it was going to be, I think it was 18 hours a day mid-grade. It would be 24/7 mid-grades in the department, 365 days a year, as well as all the kind of supplementary support tiers underneath. And there's also going to be consultant oversight cover for 40 hours a week, which was in line with the consultation. The change that were made, the changes in terms of subset of conditions, came out of a clinical audit in terms of conditions, and also a national requirement around respiratory conditions that said these patients need this level of backup support, which isn't provided at Grantham Hospital. So all the people that go through there, 97% of the people who went through the A&E previously will be able to go to UTC. Those patients already aren't going to Grantham A&E as it currently stands, because that hasn't got the support services and the right level of care on site to look after them. So that has happened because it's the clinical model. But actually, what we're consulting saying, this is an urgent treatment centre. It'd be a very highly spec'd urgent treatment centre, have a significant level of care with a diagnostic capability 24/7, have phlebotomy support 24/7, and it's got an inpatient ability to kind of allow patients or say they need to be kind of admitted into the wards as well. So it's going to be a high level spec. So it isn't going to be too different to the service that was on, well, that was in place before, but it's going to be rightly designated as an urgent treatment centre. The key bit with this is the people who really need to know the finer detail on what can and can't go there are the ambulance service, and they're well versed in what the exclusion criteria for the site are. So if you have one of those acute episodes that you need an emergency response, you're going to call EMAS, and they're going to know the right centre to take you to. That might be Grantham, it might be Lincoln County, it might be NUH if it's major trauma. So the instance of a road traffic accident, if it's very severe, that actually you're going to Nottingham more than likely than you are going to Lincoln County. So to answer the question, no, the service won't be too dissimilar, but it'll be correctly categorised as an urgent treatment centre and not an A&E.
Thank you, Chairman.
Well, Councillor Lundworth's not finished yet, so...
Yeah. Sorry, Pete, I also said when and where will you give us a date?
Sorry, yeah, apologies, forgot that part. In the next month, we will come back to you and inform the committee in writing when when the opening date will be. What we want to do is make sure that date is agreed and fixed, and that's it in that sense. And that's what we just need to get right.
Thank you, Chairman. Thank you, Pete.
Councillor Morgan.
Thank you very much. But yes, just as a point of information, I need to correct the statement that Grantham A&E did not have the equivalent of A&E services after 2008. A Freedom of Information request put to the Trust in 2018, December 2018, showed that in fact it covered every level of service that you'd expect in a typical A&E. Didn't include trauma, but then, as we've already heard, nor does Lincoln necessarily either. I will leave it at that, but this is a real bone of contention because the Trust repeatedly are stating Grantham didn't have an A&E to justify its decisions, and it is incorrect. That's every level and every acuity as well. Thank you.
Thank you. Councillor Cleaver.
Thank you, Mr. Chairman. Yes, Pete, thank you for your report. I have to say I'm a little bit disappointed with the section at the end of section 5, which is entitled Phase 3 Implementation. Firstly, because it doesn't obviously have an opening date, but you've obviously answered that point as best you can now. Secondly, it doesn't say exactly what services the UTC is going to offer, which again is disappointing after all this time and times that this has been debated. I had a quick look through last June's papers while the meeting's been going on and couldn't find any reference there. So apologies if it is there, but I certainly couldn't find it just now. The other thing then is a slight concern because of the sentence in there which reads, however, during the process to develop implementation plans for the service, there is a need to review the on-site out-of-hours provision provided by LCHS to avoid duplication in service offering. And that concerns me, because it surely, if there was such a need to avoid duplication, it should have been identified way before you were at the implementation stage. I mean, am I to infer from that that you're saying that there's going to be a 24/7 UTC, therefore there isn't any need for an out-of-hours service? And if that, okay, obviously if that's the case, why has this not been identified before the implementation phase? Or is there some other inference there that one is to draw as to what the overlap, if any, will be between out-of-hours service and the UTC being or not being 24-hour? So if you could just clarify that for me. On if I may pray your indulgence, Chair, on a wider point, I also noticed in this paper that the UTC isn't GP-led. And it's notable that on the NHS website, its definition of urgent treatment centres says that they are GP-led. Urgent treatment centres are GP-led, but yet none of them in Lincolnshire are. That's obviously a Lincolnshire peculiarity that the ICB has adopted, and I'd love to know the reason for it. Thank you very much.
Thank you, Pete. I'll bring you in. I think GP-led, it was 8 till 8 is GP-led, wasn't it, in some of them, but overnight it was never certainly the case from what I recall. But it's the inference of not having the GP-led full stop, I think, is what Councillor Cleaver is meaning.
Yeah, and I think if you look at, I've worked in other systems, I don't think they are necessarily GP-led in that true sense. But this is because actually this will be mid-grade, have consultant oversight, but GPs will be involved in terms of developing the service spec for the site. There's GPs involved in that, and they will continue to be involved in the delivery of the services going through. But the purpose of this was not to set out the detail of the kind of service spec in detail. Is really to go from where we are in the implementation stage. But no, so that's I think there's different variations on how that works up and down the country. But no, I know other ones that aren't in that regard. In terms of the out of hours service, so the out of hours service was set up to support, because the A&E shut overnight, as I understand it, predates me, was set up to allow people to get appointments if they needed locally overnight. And the point being that the new 24/7 service will both be open access, so people just turn up and present at the site and they will be seen. But in line with the National Service Spec, there is a need. You can have bookable appointments. So if you phone through 111, they can book you into an appointment slot. So you can turn up at the agreed appointment time and be seen. And all we're saying there is there's a need to make sure that model of care is integrated with the out of hours. Otherwise, you're going to have 2 bookable appointment slots on the same site, and that it makes sense to make sure they work together. So nothing concerning that. The same service being offered, it's just making sure it's done in an integrated way, and some of that comes out of who's going to lead and how it's going to work. So in terms of who the lead provider is going to be, and that's just what we're working on with both trusts to get through to make sure the right service and it's done in an integrated approach. So no, so the service they're offering will be offered within the UTC.
Thank you. So just to make sure I've understood that correctly, thank you. So there'll be UTC staff and there will be out-of-hours GPs on the same site simultaneously at certain hours of the day, and you're simply going to make sure that people dialing 111 will be directed to one or the other as appropriate and effectively triaged when they book in. Is that correct? Have I got that right?
No, so the out of hours bit isn't overnight, isn't GP over that spec anyway. So no, so the aim will be that you book in and you book into the UTC. Actually, that service, how do we integrate that within that UTC model is the key bit. So actually, the offers there, the same provisions there as currently provided overnight, but actually it's done all in the same way. So there isn't an out of hours bookable and there isn't a UTC. It's done in an integrated model. So it's just about how we merge those two together.
Thank you for the clarification. Thank you.
Thank you. I've got Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. Thank you for returning some orthopaedic treatment back to Louth. We've got loads of spare space, so you can send other things back to Louth, please. Our urgent treatment centre in Louth is extremely good, so you don't really need to worry at Grantham. I've had personal experience of it myself. They do have a retired GP working in that department, but it runs in parallel with an out-of-hours GP service on the same site. So there is always a doctor around, but it's important that Louth and Skegness are open 24 hours or available 24 hours because our population grows and grows in the summer holidays hugely, and we have a lot of people who don't take care of themselves when they're on holiday, and so they're very necessary parts of the NHS. Could I ask you, are you going to change the staffing at Louth UTC? And I could ask if the same for Skegness, really. Is that going to go over to ULHT, or is that staying with the Community Trust as it is now, please?
Pete, do you want to cover this? The only thing I'd say is we're already with LCHS, so it won't change. This is purely, I think, for the implementation, because Grantham is making that alterations. Yeah, absolutely. And no, we would be as vocally loud, I'm sure, for Louth and for Skegness if they stopped doing 24/7 care in our UTCs, which do offer an excellent service.
Well, it did stop for a little while, didn't it? And we really, really missed it.
And trust me, we were vocal and got straight onto them between Simon and I. Okay, thank you. I have no further speakers at this moment in time. No, thank you. In which case, I've got one question, Pete, if I may, and that's: this report does not focus on the changes to orthopaedics and stroke services. When is it appropriate for an update on the implementation of these parts of the acute services review, please?
Yeah, so I think the thing with orthopaedics, the pilot been in place, so I don't mind bringing back an update, but I think the update in December provided, obviously, I think they're the best, if I remember off the top of my head, best for hip ops and second best in the country for knee ops and length of stay and all that kind of piece. We can certainly bring back a paper just to clarify where we are in the autumn, to say actually the same level of care and improvement has been seen there. I think you'll see that because obviously the amount of investment that's gone into sites with the theatres and that kind of piece, but we can certainly bring that back. And the stroke, again, we can bring that back in because the aim will be that these become business as usual, are managed in a joint way between the trusts, certainly on the stroke pathway, but we can certainly bring an update back in the autumn on where we are. And obviously there's an element of capital building in the stroke work, so we could come back then if at a time that works.
Brilliant, thank you. In which case, I'm going to make a proposal that the committee looks forward to the opening of 24/7 Grantham overnight care and implementation of the acute and community beds arrangement as soon as possible. And we're hearing now in the autumn. Do I have a seconder for my proposal? Thank you, Councillor Ray Wootton. All those in favour, please show. Thank you. Those against? And abstentions? Thank you. Supported. And thank you, Pete, for your time.
Thank you.
We'll now move on to agenda item 10, response to the paediatric service consultation. This item is set out in pages 137 to 142 of the agenda pack. It includes the proposed draft response of the committee to the consultation on paediatric services at Pilgrim Hospital, Boston, which has been drafted on the basis of the committee's views expressed at its May and June meetings. Simon.
Thank you, Chairman. Just to repeat that this has been on the agenda, as you've just said, last month and back in May, and on the basis of the comments made on the two times this has been presented, a draft response has been prepared. It has been circulated on email to members of the committee prior to being released as part of this agenda. It's also been available on the agenda for a week. During that time, I've had no further suggestions for any comments on this. Just to reiterate that the proposal essentially is to make permanent the existing temporary arrangement which has been in place at Pilgrim Hospital for paediatrics essentially since 2018, but has developed over time. So it's really making permanent the developed arrangement, not the initial arrangement that was put in place in 2018. I'll leave it there and leave it for the committee's consideration. Thank you, Chairman.
Thank you, Simon. I'd just like to say from the chair, thank you, Simon. I think it's incredibly well written up. It's encapsulated everything that I think this committee has raised. And thank you for taking the time, and I'm happy to propose it as it is now. Any other comments? And do I have a seconder, please? Councillor Mackinson-Sanders. All those in favour, please show. Thank you. That's supported unanimously. In which case, we'll now move on to agenda item 11, the work programme. Over to you again, Simon.
Thank you, Chairman. If I could just ask the committee to look at the future items which begin on page 145. There are 4 items listed for September. Unfortunately, the Humber Acute Services Programme, I think, as the Chairman mentioned at the very beginning of the meeting, is still to be confirmed. Still working on that one. And just to clarify number 3, that should actually include, although it may need to be a separate item, but perhaps that's for further consideration. It says children and young people services, but it's also older adult services, the services which are traditionally, and I know we were told earlier that the age boundaries are not hard and fast as they used to be, but services for people aged 65 and over, which is a separate division and wasn't covered by this morning's presentation. Just looking down, obviously this morning the date for the October meeting was confirmed as the 4th of October, and I won't go through all the items listed for the subsequent months on pages 146, but I'm happy to take a note of any comments made by members of the committee. Thank you, Chairman.
Thank you. Any comments to be made, please? Yeah, Councillor Cleaver.
Sorry, just fairly informal comment, really. When are we due to have NWAFT talking to us again? Seems. Sorry, Simon, I can't remember when it last was. It's normally an annual thing, isn't it? And
yes.
It looks like we could possibly put it on the 8th of November.
They were in January of this year, so it should be January, perhaps January, February of 2024. Thank you.
I'd probably go further and say probably February to let the new chief exec start coming in and getting that introduction, perhaps. Yeah, certainly.
Sorry, yes, so because there is the issue of the minor injuries unit at Stamford Hospital, which, dare I say it, seems to be in risk of being kicked down the road.
Yeah, it's difficult, that one, because it's kind of the ICB. I think there is a will from NWAF that they may like a certain way of moving forwards, and the ICB potentially wouldn't agree necessarily it needs that level. But I think it's something that we'll certainly pick up again when we have our agenda set in, just to make sure it keeps on that radar. So, Councillor Morgan.
Thank you. We previously discussed inviting the health bodies to come forward and tell us how they are going to manage with the growth plans, the development plans that are going on across the county. And I can't see that on here or where we would have that feedback. Thank you.
Yes, apologies. That's Councillor Morgan. Apologies through the chairman that that's not been included. That is a valid item. I mean, one of the ways that perhaps it could be dealt with is to raise it as a specific issue, as a theme on each item that is considered, in terms of, so for example, last month with GP provision. But perhaps the view of the committee, I think I'm sensing, is that there needs to be an overview of this to kind of pull all the strands together rather than picking it up as a theme. So I'll look into that. Thank you.
Okay, any other comments on the work programme? No, in which case we're happy to move forward with it as it is. Thank you. Okay, all those in favour, please show. Thank you, that's supported, and thank you all for your attendance. It wasn't too bad this afternoon, was it, what do you say? Thank you all very much. Have a safe journey home.